Good morning, everybody. Good morning, good morning, good morning. All right. So, everybody, go ahead and look at the screen here. Nice, simple animation of breathing. And what you'll notice is every single time we have inhalation, go ahead and make it big. Every single time we have inhalation, what's happening to the volume of the lungs? Increase, decrease, no change. How? This is the thing that tricks students up every semester. The volume of your lungs is dependent on muscles, but there are no muscles on your lungs. And that's why I spend so much time talking about the inflation of the lungs. The fact that the lungs are inflated and the fact that the lungs are adhered to the thoracic cavity wall is stupidly important, because we have muscles to move our thoracic cavity wall. We don't have muscles to move the lungs. Is that clear? This is a huge topic that students miss semester after semester after semester. If I ask on a test to describe ventilation, don't tell me the thoracic wall increases in volume, therefore we breathe. It doesn't work like that. Cool? Am I clear? Thoracic volume increases, therefore changing pressures because of the muscles. Then the lungs follow because of their adhesion to the thoracic cavity wall. Awesome. Now, what primary muscle do we know is involved in breathing? Whether it's passive breathing or active breathing, it doesn't matter. So what I want you guys to do is watch this video here, this animation. And I want you to imagine that the diaphragm's down here. The diaphragm is not in this animation, but in passive breathing, really, when it comes down to it, only the diaphragm is involved. So what you'll notice is what primary region of the lungs is expanding in size, the apex or the base? Yeah, it's the base, which is awesome because that's the biggest part of your lungs, of course. So we're going to get more of a volume change here, more of a pressure gradient throughout. Air is going to go everywhere, but air is going to get vacuumed down to the bottom of the lungs a little bit better. Cool. Awesome. I hope these animations are at least helpful in the visual. These are great too for labeling. Like, check it out, you know, superior, middle, inferior lobes on the right side, and superior and inferior, you got your fissures, you got your trachea and your larynx and your thyroid cartilage and your cricoid cartilage, your different tracheal cartilage rings. So pretty cool. All right. So not a bad place to be able to test yourself. Lots of other cool animations. If you just search for animations, that will help you understand this. You don't have to have everything drawn out for you. Although Ninja Nerd's one of my favorite, by the way, if you want to go in and watch another thing. These things are like an hour long, but I love Ninja Nerds. Okay, and that's exactly where we left off yesterday, is what do we know about ventilation is that it's the physical act of breathing. And what do we know? We can write immediately when we see that word ventilation. What's going to help us on our exam? What can we write when we see the word ventilation? What will help us? Exactly. So when we're talking about ventilation, one of the very first things you should do, it might not always help you, but you should get into good habits. Is that on a scratch piece of paper or on your exam, you're going to go, I'm probably talking about airflow somehow. We know airflow is proportional to a pressure gradient. We're going to have to create that pressure gradient all over resistance. Pressure gradients just don't exist if the lungs aren't inflated. I hope I'm making myself clear. Hint, hint. And most likely scenario is I'm going to make you talk about the inflation of the lungs. Those lungs must be inflated. And the inflation of those lungs is related to those pressure gradients. What's happening inside of the lungs, the intraalveolar pressures. What's happening inside of the pleura, the intrapleural pressures. And it's the difference between those pressures. It's the difference between those pressures that's going to determine whether or not there's a vacuum, whether there's a subatmospheric pressure, and therefore whether or not those lungs stay inflated. There's also some surface tension thrown in there. And then the fact that the lungs are trying to recoil, the fact that the lungs are trying to kill you is actually important because they play into Boyle's law as well. So your lungs are inflated due to three major reasons, right? One is just surface tension. Surface tension due to there being a pleural cavity. Two, the transmural gradients, which is the pressure gradient between the alveolar pressure and the intrapleural pressure. So pressure gradients between intraalveolar and intrapleural. Right? We need to have a subatmospheric pressure. We need to have a negative value between the intrapleural and the intraalveolar pressures. And the last thing that's involved in this, and this is going to come back into play in the resistance as well, but is the elasticity of the lungs. Surface tension is a property of water. There are 7 properties of water that make it essential for life. Without water, we wouldn't be alive. One of those properties is surface tension. So surface tension is a property of water. Pressure gradient has no relationship to water at all. Pressure gradient is just the difference between pressures. Surface tension allows for an adhesion between the two pleural walls. The visceral pleura is going to have surface tension that's adhering it to the parietal pleura. The pressure gradient now creates an additional vacuum that helps hold that surface tension. Yeah, surface tension is created by the serous fluid, absolutely. Perfect, no problem at all. Now, the pressure gradient is reliant on the elasticity of the lungs. As weird as that may sound, the lungs need to be recoiling in order for there to even be a gradient to begin with. Not everybody has played around with a syringe before, but if you're ever at work in a hospital or something like that, you got like a big 60 cc syringe or 100 cc syringe. put your finger on the end of that syringe. Gosh, I have one out. Well, I don't know where it's at. But if you take and put your finger on the end of a syringe and pull the plunger, you've created a closed system because you put your finger on the end, and then you increase the volume inside of that plunger. You guys know what I'm talking about? Some of you do, some of you won't. So what happens when you let go of that plunger? Right? It's a vacuum, so it's going to pull that plunger back to its original position. It's not snapping back. It's not elasticity, right? That's Boyle's law at play. It created a vacuum. Does that make sense? I hope that's helpful in terms of your analogy for how the lungs are staying inflated. You're creating that vacuum, that same vacuum that would be produced inside of a syringe. Well, that's inside of your pleural cavity. But you can't have that if you're not pulling on the plunger. Just close the end off, you have no vacuum. If you pull the plunger out, then put your finger on the end of the hole, you have no vacuum, right? You have to put your finger on the end of that hole, then pull the plunger, now you got a vacuum. Does that make sense? It's crucial. That elasticity of the lungs is absolutely crucial. You start losing that elasticity, you start losing that pressure gradient. You start losing your vacuum, and you're definitely more likely to have a pneumothorax, one of those spontaneous pneumothorax. Does that make sense, everybody? I hope so. Cool. The other thing now, once the lungs are inflated, now we're going to have muscles moving. And the whole point of going through muscles isn't to remind you guys of every single muscle in your thoracic cavity, because they're all involved in creating pressure gradients. The whole point of understanding the muscles is that we have different muscles involved in inhalation, we have different muscles involved in exhalation. Primary muscle that's involved in both, it's the only muscle that's involved in both really, is the diaphragm. But what those muscles are doing is they are following Boyle's law. Okay, that's what muscles are doing. They are taking care of Boyle's law. They are your syringe, but now they're the syringe of your entire lungs. Because as the thoracic volume increases, what happens to pressures in that system? Increase, decrease, no change. So they are inversely proportional. Muscles are all about Boyle's law. Muscles are designed to change the volume. That's what they do, right? So muscles, they change the volume. And therefore, what happens to pressures? Therefore, it affects pressures. And as we change the pressure, now we're creating gradients. Does that make sense to everybody? So we just determine how we get this delta P. Got to have those lungs inflated. Then we start changing the volumes. And as we change the volumes, the pressures do their thing. Awesome. Hopefully everybody feels pretty comfortable with that. What muscles do you guys need to know about? Well, you definitely need to know the ones that I have pink arrows next to on this lecture. So on this particular table here, don't overthink it. Tons of muscles involved in breathing. If you want to learn them, great. If you're really into, exercise, for instance, right? If you're just in, I'll tell you a story that works along with this in just a second. Actually, that'll help, I think, the most. I keep trying to move down and it's not letting me here. I'll just zoom back out again. Now, there are muscles that are involved in quiet breathing, and quiet breathing is the same thing as passive breathing. And recall, yesterday I described passive breathing as breathing without thinking about it. Okay, so if you're breathing and you're not thinking about it, which is most of your life, the primary muscle that's involved in that is diaphragm. Because the way that the diaphragm works is as the diaphragm contracts, it starts as a concave muscle. It's this big, huge concave muscle. And as it contracts, it flattens. Flattens. Contraction, relaxation. Contraction, relaxation. Contraction, relaxation. And each time it contracts, the volume of the thoracic cavity increases in size, therefore the lungs follow. And each time it relaxes, the volume of the thoracic cavity decreases and the lungs recoil back to their original position. So breathing is mostly just the contraction and relaxation of the diaphragm. How crazy is that? One muscle does a big job. It's not the only muscle that's involved. You also have those external intercostal muscles. That's involved in passive breathing. It's primarily involved in inhalation. Okay, it's going to help increase the dimension of the thoracic cavity. Now, what do we know about both of these muscles? This is mechanics of quiet breathing. It doesn't mean it's just inhalation. It's also exhalation. So how can these two muscles both be involved in inhalation and exhalation? The answer comes from when they contract, the volume gets bigger, and when they relax, the volume gets smaller. Does that make sense? And yesterday, to finish things off, I had you guys breathe in super duper deep. You could start feeling your chest getting involved. Portions around your latissimus dorsi are getting involved, not the lats themselves, but some of the smaller muscles around there, like the scalenes. And the erector spinae gets involved. You have to start sitting up taller and taller and taller with a nice straight back to get the most out of your breath. So as we start to force or actively breathe, when we think about what we're doing, it's going to start to involve a lot more muscle groups. What's the function of each one of these muscle groups? If I'm dealing with forced inspiration, what's the function of every single one of these, whether you remember their names or not? Really simple, guys. Should be a fast response. Not ventilation, not ventilation. We know this is all part of ventilation, so maybe I didn't ask the question correctly. Maybe I misled you guys down that path. This is all ventilation. This is active ventilation, and this is passive ventilation. So if I'm going to force inspire, I get this pink group of muscles. All of them have one thing in common. That's to increase the volume. You guys are kind of skirking around it. A couple of you got it. Heather, great job right off the bat there. Everybody, great job for at least trying to answer there. I love that. Absolutely love it. Please keep answering. I never want to get you guys feeling, dejected in your answers. This is all about learning, and learning's about being wrong sometimes. So keep that in mind. But this is what I was trying to allude to yesterday. You don't need to overthink these muscle groups. If they contract, and they're involved in inspiration, inhalation, same thing. What do you know about their contraction? The function of their contraction is to increase the thoracic cavity volume. Does that make sense? So don't overthink. Expand and contract, those sorts of things, Andy. They're all going to contract and relax. Every one of these muscle groups contracts and relaxes. Now, forced expiration, internal intercostals, abdominal muscles, transversus thoracis, serratus posterior or inferior. When these muscles contract, yes, contract, the function of these muscles as they contract is to decrease your thoracic cavity volume. That's the point I'm trying to make. Does that make sense? These muscles are contracting, but their function isn't to increase the volume. Their function is to decrease the volume. And prove it to yourself by breathing out as deep as you possibly can. And you'll definitely maybe 100%, 60% of the time, start to feel those abdominal muscles start to contract. So here's the story that might help you guys understand why this is relevant clinically. There are a lot of muscles involved in active breathing and passive breathing. Passive, diaphragm, external intercostal. So there's two things to think about. What would happen if we ever had nerve damage? You guys might not even know this. I'm just going to write it because we got time limitations. There's a major nerve that I make sure my A&P1 students learn. That's the nerve that innervates the diaphragm. Oh, lovely. Andy Rujuga, you guys got taught this. This is great. This is great. I'm trying to multitask here, but I'm going to type it in chat here. There is a nerve, it's called the phrenic nerve. The phrenic nerve is the one that innervates the diaphragm. So what would happen if somebody, a patient, had phrenic nerve damage? Gulp. This is a big deal. They're going to have trouble, massive difficulty in breathing, and it's not very fixable. Okay, phrenic nerve is a really important nerve. It runs down right next to the carotid artery. It's that important. Like the major blood supply to the brain, running right next to that is the vagus nerve and the phrenic nerve. Sound like they're pretty important nerves to me. This is something that's really bad with diabetes. Type 2 diabetes, left unchecked. I'm talking about uncontrolled type 2 diabetes. This ends up causing neuropathies. In like 90% of type 2 diabetics, they end up with neuropathies, which means damage to nerves. And diabetes type 2 that's left unchecked, what ends up killing most of those patients is damage to that phrenic nerve. High impact accident. Anybody watch those movies where, you know, the Bruce Lee walks up behind somebody all sneaky silent, and then he just, or, you know, Jean-Claude, whatever, the Jean-Claude Van Damme, you know, they go up behind them and they snap their neck, twist their neck, snap their neck. So what they're doing there is they're severing the spinal cord, but they're also, more importantly, severing the phrenic nerve. So that's what that particular move is designed to do, as freaky as that is. Other things. The phrenic nerve is direct. We'll get into the innervation of the diaphragm and, you know, the act of breathing in terms of nervous system controls. But this goes to a specific portion of your medulla oblongata called the respiratory groups. Awesome. We got respiratory control centers in our medulla oblongata. By the way, the medulla oblongata is really important. And those respiratory centers are going to be one of the ones that are most severely impacted by CNS depression, alcohol poisoning, and drug overdoses that kill people. What they're doing is it's a CNS depressant that's inhibiting the respiratory centers that control the phrenic nerve. So no action potentials go down that phrenic nerve, and that patient stops breathing. Is this starting to tie in? Like, these muscles aren't boring. They sure can be if we don't pay attention to them, right? But if you start thinking about how the whole entire system works, we can't get action potentials down to these muscles. We're not breathing. Make sense? So my personal story that really I mean, I hadn't even taken physiology at this point, so I didn't really know much about what was going on, but I used to be a huge mountaineer, rock climber. Just every free second that I had, which wasn't a lot, but I was down at the rock climbing walls or out caving or something with my buddies. And I was doing this pitch, and it was kind of an inverse pitch, and I was hanging upside down in this basically this outstretched cave, and I had a suitcase hold, which means a big, huge, chunky hold with my right hand, and I had a heel hook with my with my heel. Basically, it's just a move that you can do. Well, my suitcase hold, my hand slipped, and so I was hanging about 15 feet up by my heel. How do you guys think that went? It didn't go so well. It didn't go so well. I fell straight down, and I landed on my left shoulder. It's not soft. I got up, and I couldn't breathe. I couldn't breathe. No, I got big bones. It didn't dislocate. I was very surprised, but I couldn't breathe. I was screaming. I was crying. Oh my gosh, I was crying. It hurt so bad. I was screaming, and I felt like I was dying, and I thought I had punctured my lung. That time I didn't even know what a pneumothorax was, but I couldn't breathe. I was sitting there and I couldn't breathe. Every single time I tried to breathe, the pain coursed through my body, and I couldn't breathe. And my buddies, we get me in a car, but we're hours away from a hospital, so we're driving. I'm screaming this whole damn time. I'm like, I can't breathe. I can't breathe. I couldn't breathe on my left side. Every single time it felt constricted and tight. Got to the ER. They took x-rays. Not a single broken bone. Long story, a little bit shorter. It's still pretty long. What had happened is I'd torn my pectoralis minor. That's it. I'd torn my pectoralis minor on my left side, and that in and of itself was enough to make it so that every single time I tried to breathe, which is deep breaths, which you're doing, especially when you're in pain, every time I tried to take a deep breath, I couldn't get my thoracic volume big enough to help me with inhalation. So I felt like I was suffocating the whole time. Kind of tells you the importance of these muscle groups, whether or not you need to know them specifically for the exam or not. But someday you might see a patient with damage to one of these muscles, and they're going to have difficulty breathing. Does that make sense? All right, cool. Boyle's Law. We're experts on Boyle's Law. P1V1, proportional to P2V2. You do not need to know this one for the test per se. You can simplify the heck out of this. As the volume decreases, the molecules move closer together. Therefore, the pressure increases. Decrease versus increase, well, that tells us they're inversely proportional. Remember, the volume determines the pressure. The pressure does not determine the volume. Am I making myself clear? The right side of the equation impacts the left side. The left side does not impact the right side. So don't be telling me, if I talk about pressures on an exam, don't be telling me that volumes change. That's not how it works. The pressures don't determine the volumes. The volumes determine the pressures. It's all about muscle groups. As those muscles, primarily the diaphragm, contracts, the thoracic cavity size gets bigger. Ribs get elevated. All sorts of changes to the bone structures of the thoracic cavity, and the volume gets bigger. And as we exhale, the volume gets smaller. Easy peasy lemon squeezy. So here we are in that same exact idea. This one's super simplified, Boyle's Law. This particular case, as the volume is large, the pressure is small. Same number of molecules, but more room to breathe, so to speak. Bad pun, dad pun, I know. I know. More room to breathe. There's more room for those molecules to move around, whereas when we start to compress them all together, ACL. That's Austin city limits for those that, don't live in Austin. Have a connection to the outside world. Area A would be the atmosphere. Area B would be your lungs. Area A never changes, hopefully, unless you get confined into a small box. Please don't ever let that happen to you. Area A should be a nice huge area and the molecules roam freely. You're not going to be sucking the molecules out of Area A, and Area A volume's not going to be changing. What area changes? Area B, inside of your lungs. So what we do is we increase the volume, decrease the pressure. Now air can flow from an area of relatively high to an area of relative low. Versus when we breathe out and that volume gets smaller, then the pressure increases and it's going to increase above what's going on in area A. Therefore, air is going to flow from area B to area A. You guys just stop me if I'm going too fast. I'm just trying to get through this stuff. We got a lot to do. Area A is the atmosphere. Atmosphere, the air around your face. And that volume's not going to change ever. And hopefully the number of molecules doesn't change ever either. So we can look at this graphically. For those that love graphs, I do. One breath on the x-axis, volumes versus pressures on the y-axis. So the volume one's really easy. Everybody breathe in. What just happened to the volume of air inside of your lungs? Increase, decrease, no change. And this is talking about the volume of air. This isn't talking about just the volume of your lungs. It's actually saying as you breathe in, there is a volume of air that enters your lungs. As you passively breathe, the average volume of air that enters your lungs is 500 mils. That will be a number you guys need to know, especially for lab today. So you might as well write it down. During passive breathing, the volume of air that goes in and out of your lungs is about 500 milliliters, about half a liter of air. Every breath, every quiet breath. We can get a lot more than that when we actively breathe, but we'll be doing that experiment in lab today. How many milliliters during passive breathing, y'all, are going in and out of your lungs? This volume is called the tidal volume. Okay, this is called the tidal volume. We abbreviate that TV, luckily, right? People tend to be able to remember TV. So TV is equal to approximately, where's that approximate? There it is. Approximately, TV is equal to, man, and all sorts of wrong buttons. Equal to approximately, don't worry, I'll get there one of these years, 500 mils. Sorry, I'm trying to write it down for you. All right, cool. That will come back into play later today. Now, what's actually happening to the pressures is different than what's happening to the volumes. I am not sure what you're referring to, Melissa. I must have missed something in current events, but you can tell me later by text. Let's not. Oh, George Floyd. Yeah. I haven't watched that. Yeah, I'm not sure what that Irish pulmonologist said, but I can look that up later. Okay, let's look at the pressures though. The pressures, do you guys notice that the pressures are doing a whole bunch of weird stuff? So let's look at those pressures and try to understand what they're even referring to. The red line is intrapulmonary pressure and the blue line is intrapleural pressure. I think starting with the intrapleural pressure is actually easier because is this an open system or a closed system? Inside of the pleura, the pleural cavity, is that open or closed? Inside the pleura is closed, thank goodness. It's a closed system. We did that, we drew that out yesterday, right? It's enclosed inside of that thoracic cavity wall. So we know that it follows Boyle's law completely. Cool. So as the volume increases, boom, pressure decreases. Make sense? And now as the volume decreases, pressures go back to normal. So we become even more subatmospheric as we breathe in, which now holds the lungs in an even tighter vacuum. Pretty cool. The problem with intrapulmonary is that this is connected to the atmosphere. There is a tube that allows atmospheric pressure to equalize. I tried to refer to this quite a bit yesterday. There's a tube that's allowing those lungs to equalize their pressure. So as the volume increases and the pressures are dropping, that air, that 760 millimeters of mercury, is going into your lungs. So even though it starts dropping, we're going down to about 758, well, 760 is entering your lungs. Does that make sense, y'all? So it really ends up balancing out. And look, at some point, we are not increasing our volume at the same rate. We increase our volume very quickly early in a breath. But look what happens to that volume change here on the tail end, the last third of this graph. It's a much flatter line. True story? And at some point during passive breathing, the volume no longer increases. And if the volume's not increasing, then the pressures are going to equalize. So as bizarre as it may seem, during one inhalation, at maximum inhalation, the pressure inside your lungs just 760. And then as you exhale, you're blowing air out. You're blowing air out. The pressures inside your lungs are definitely going to increase, but they are also going to end up equalizing with the world around you. And I'll be teaching you more about what's called dead air and stuff like that and why equalization is occurring a little bit better. But that's what this table is a representation of. So make sure you have a basic understanding of the volume pressure relationships, pressures in both the intrapulmonary space and the intrapleural space. One more schematic of what you guys have already learned. But now I throw in numbers. At rest, the air in the atmosphere and the air inside of your lungs are at equilibrium. As long as there's no pressure gradient, there's no movement of air, therefore everything is equalized. What's going to happen to the size of the lungs when the thoracic volume increases? Well, the lung volume is going to increase right with it. Perfect. Because it's adhered to the thoracic cavity wall via the surface tension, the pressure gradients, and the elasticity of those lungs. Boom. Awesome. So now the second that the pressure inside the lungs start to drop, air gets to flow from high to low, and that's what inhalation is. Versus expiration, exhalation, when we contract the muscles of our thoracic cavity, the thoracic cavity volume decreases in size, and the lungs are finally able to recoil. Awesome. As the volume of our lungs decrease, the pressure inside those lungs increase, we have a pressure gradient. It's going in the opposite direction, but we have a pressure gradient. And pressure allows for the air to flow out of our lungs. I hope you guys understand airflow. We probably spent a little bit too much time on it, but I do test on it a lot. So I definitely want to make sure that you guys understand that there are three major properties that create this pressure gradient. First, we must have inflation. Second, muscles are going to follow Boyle's law to be changing the volume, therefore pressure changes with it. Yes, no, maybe so? Cool. So now let's define resistance. And resistance is exactly what you've already learned. Resistance. What is the primary factor that's going to be causing a change in resistance? You guys, I think you're experts at this by now. What's the primary factor? What has the most power on resistance? Diameter of those tubes. And the bronchioles have smooth muscle around them, and therefore we can impact the diameter of these tubes relatively easily. But those are not the only things involved in resistance. So let's just quickly go back to here, and I'm going to be talking about resistance now. And we know that resistance is proportional to actually a bigger picture than just 1 over r to the 4th. We know that there's a length that's involved in this, so 8 times the length. We also know that there's viscosity involved in creating resistance. We know all of that is related to the diameter of that tube. Length, viscosity, and the radius of that tube. We discussed this both with blood vessels, and we discussed it yesterday with your conduction system. Lung length, right? The length of all of your conduction system, it shouldn't change in normal physiology. True story? I mean, it's not like we're not changing the length of our respiratory conduction system much. Now, we'll come back to that, Heather. Yes, yeah, definitely. We discussed that a little bit yesterday too. But yeah, the length, what I want you guys to be thinking about immediately when you see a patient that's 7 feet tall versus a patient that's 5 feet tall, and if they're having respiratory issues, you guys should be more concerned with that tall person because they are going to have more resistances through their tubes. In other words, their lungs are going to have to work harder. The muscles of their lungs are going to have to work harder to create larger pressure gradients to counter the resistances that their tall bodies are producing. Does that make sense? It's all about equilibrium. Nah, that's the wrong word. It's all about homeostasis. Now, viscosity, exactly, Heather, right? Viscosity. If you got 100% humidity of the air, problem potentially, but even more of a problem is when you start to hypersaturate that air. I don't know if it's necessarily a problem, but we got to think about it. The example that I always use, and I used it yesterday, is that if you go to a spa, if anybody's ever been in a spa, if anybody's ever been in a sauna, for instance, and somebody starts throwing water onto the stove in one of those saunas, then the air doesn't just become 100% humid, it actually fills with vapor. Yes, no, maybe so? It becomes hypersaturated. There's actually liquid in the air. It's not just 100% humid. There's actually like a fog. Yeah, exactly. Yeah, we talked about running in different conditions yesterday too, Heather. Like, you know, I lived in Tucson, Arizona, all the way up to Alaska. So, you know, and I rode crew in Eastern Washington. So running in all sorts of different temperatures. I'll tell you what, breathing is completely different depending on where you're at. I used to actually mountain run up in Salt Lake City a lot too. And the air there is very, very thin. So that changes the viscosities and the resistances and how well you breathe. But it also is going to change the amount of oxygen in the system. Okay. We'll come back to these other two factors. We're going to write them in. But these two factors right here are going to be some additional factors that are involved in resistance we need to keep in mind. But I want you guys to focus on what you already know. I want you guys to focus on what you already know. Factors that affect the airway resistance, length of the system. It shouldn't be a factor in a normal patient. Viscosity of the air shouldn't be a factor unless we are at different, you know, locations. But then it should be a constant between each patient that you see. If you live in Miami versus if you live in Salt Lake, you're going to be seeing a different subset of respiratory patients. Diameter of the airways is the #1 impactor, but we got to start to think about more than just bronchial dilation and bronchial constriction, although those are two things we're going to be talking about. We also need to think about the upper airways, because if the upper airways get blocked, hot dog, phlegm. That's one that I like to think about, is the cold, because we've all had one of those nasty colds in our life where our nose just gets completely plugged with schnat. You breathe better, you breathe worse. I mean, it's a pretty easy idea. And as you breathe worse, less oxygen starts getting into your body, and it's going to have a big impact on how well you can heal. It's pretty bad. Bronchioles, though, is going to be the #1 thing that I test you guys on. Bronchoconstriction, bronchodilation. Bronchodilation increases the diameter. Bronchoconstriction decreases the diameter. We breathe worse, per se. We breathe better, per se, although it's not always a worse or better, because it's always about homeostasis. Does that make sense? So the diameter of our bronchioles isn't always constant. If you live in a house with a 2nd story, just run up to the 2nd floor. What's going to happen to the oxygen demand in your body? Increase, decrease, no change. Not to mention the amount of CO2 in your body just increased, and I'll teach you guys all about that today as well. So do we want smaller diameter bronchioles or larger diameter bronchioles so that we can flow more air through that given period of time? Yeah, we're going to want bronchodilation. So this is a sympathetic nervous system guy down here. If you're running from Mr. Axeman, do we want to breathe more air or less air? Versus if you're just chilling on the couch digesting, 47 hot dogs, please don't ever do that. Then we don't need a lot of air going to our lungs. We need just the right amount. This is a balance between the parasympathetic nervous system and the sympathetic nervous system. But what I want you guys to see is something special, unique, and a little bit different than what you guys saw with blood vessels. In blood vessels, since we got to review all the time, what is the only type of receptor? This is a general category of receptors. What is the only type of receptor found on blood vessels? General type. Actually not cholinergic. So cholinergic binds acetylcholine. Great try, Melissa, because I was looking for a general name like cholinergic. Not beta-1. We don't find any beta-1 on blood vessels at all. And I'm not asking for alpha, because there's both alpha-1 and beta-2. So I'm looking for a general name. Sorry, I've been trying to use the same language through the semester. Adrenergic. Good. Does that make sense? I'm sorry if I confused anybody. You guys are like, what the hell's a general name? Okay, cool. So on blood vessels, we find adrenergic receptors. We do not find cholinergic receptors. There's no muscarinic receptor on blood vessels. Now, here, we do find beta-2 adrenergic receptors on our bronchioles. We do. But what do we know about beta-2 adrenergic receptors? What neurohormone prefers beta-2? If you guys remember the whole preference thing. Where's that? I'm trying. Yeah, so I think what you're thinking is beta cells at the islets of Langerhans. You made that connection, and beta cells of the islets of Langerhans secrete insulin. That's my guess is where you came from there. We're talking about those adrenergic receptors, of course. So if you recall earlier this semester, everybody, this will be important for controlling that diameter. is that we have norepinephrine. I apparently really love this blue today. I keep grabbing it. We got norepinephrine. Well, that's a neurotransmitter and a neurohormone, right? So we got norepinephrine. Oh yeah, alpha-2s will definitely impact insulin secretion. But norepinephrine, that prefers alpha-1 adrenergic receptors. You guys remember me going through this? Alpha-1 is found on your blood vessels. This is kind of funny. I didn't do this exactly right, but let me turn this around. I did this slightly different last time. I did epi here. I did alpha-1 basically as part of the table. So alpha-1, norepinephrine prefers to bind to alpha-1 greater than epinephrine. Epinephrine's still going to bind to alpha-1, but norepinephrine is greater than epi in terms of its affinity. Now, what about beta-1? Well, beta-1 is the honey badger, right? It don't care. It just wants to be activated. It doesn't care how it gets activated. Norepinephrine or epinephrine, it doesn't really matter. But what about beta-2? Beta-2, it can bind norepinephrine, but only when norepinephrine is released as a neurohormone. And if that's the case, there's still always going to be epinephrine in the system. And epinephrine binds at a much greater affinity to beta-2. Why is that? Goes back to a reason that I mentioned earlier, but students always forget. It has to do with this word innervation. Innervation is always going to be related to a synapse. And if I have a synapse, what does that tell me? That tells me I have a terminal bouton. So anytime that I'm talking about innervation, you guys should be thinking about terminal boutons. You should be thinking about action potentials that make it to that terminal bouton and open up voltage-gated calcium channels, calcium influx, therefore exocytosis of that neurotransmitter. Innervation always leads to this idea of the release of a neurotransmitter. Alpha-1 is always found on the other side of a terminal bouton. Okay, it's on the postsynaptic membrane. Beta-1 is always found on the other side of a terminal bouton. It's on a postsynaptic membrane. So alpha-1 and beta-1 are always going to be related to innervation versus beta-2. Beta-2 are just receptors primarily just found out and about. Okay, they are more random. Most beta-2s are not found at the end of a neuron. There's not a synapse to beta-2. But this should make sense. Okay, so I'm going to put it in as a very generalization. I'm going to say no synapses, no innervation on beta-2 adrenergic. So how the heck do beta-2 adrenergic cells, how do they get activated then? No synapses? Well, that tells us that neurotransmitters aren't activating beta-2 adrenergic receptors. Does that make sense? If I don't have a synapse, it's not a neurotransmitter that's activating it. Rather, what is going to be activating beta-2 adrenergic receptors? Neurohormones. Now, which specific neurohormones? Norepinephrine and epinephrine. But this is not norepinephrine that's been released at a terminal bouton. This is norepinephrine that's been released from the adrenal medulla. Does that make sense? So this Norepinephrine, epinephrine. This is adrenaline. Is this released every microsecond of every day? No. When is this neurohormone, when is adrenaline going to kick in? Only in an emergency situation. So if we work our way backwards on this, yeah, exactly. Bears, Mr. Axeman's, moose, hippopotamus, those guys are nasty. Then that tells us that beta-2 adrenergic receptors aren't normally activated. Okay, they're sitting around, they're pretty bored, and they're really only going to come into play when we have fight or flight. Yes, no? Do you guys see the link, the logic behind what I just tried to teach you? So why is this important? Because if you look at bronchodilation, it's controlled by beta-2 receptors and something else, carbon dioxide. So bronchodilation is an epinephrine thing. Epinephrine is going to have to be in the system in order for beta-2 adrenergic receptors to be activated. And once those beta-2 adrenergic receptors are activated, we bronchodilate in an emergency response. So what's going to be the #1 control of bronchodilation then? If it's not epinephrine, what's left over? Carbon dioxide, which we're going to be talking about more today. But carbon dioxide is the #1 control of bronchodilation. If carbon dioxide is building up inside of your body, we don't like this. So carbon dioxide is building up inside of your body. What are you going to do to your bronchial diameter? Increase, decrease, no change. Do we want to increase that diameter so we get better airflow? Or do we want to decrease that diameter so we get worse airflow, retain even more carbon dioxide, and we die real fast? Yeah. The more carbon dioxide that's in the system, the more those bronchioles are going to dilate. And it's just an automatic, there's carbon dioxide sensors on those bronchioles, and it's going to be responding to the amount of carbon dioxide in that system. It's pretty cool. There's actually a lot more going on than that even. Basically, the blood ends up shunting away from areas of low carbon dioxide to push more blood towards areas other areas in the lungs. It's a really complicated system. I don't end up teaching it to you guys. I think it's just too complex. Bronchoconstriction, on the other hand, is a lot easier to understand. It is basically controlled by parasympathetic tone. The parasympathetic nervous system is always acting on those bronchioles. That's the vagus nerve, y'all. Viva Las Vegas. The vagus nerve. So acetylcholine is released on muscarinic receptors, at which point, oddly enough, acetylcholine is excitatory. Exactly, cranial nerve 10. It's my favorite cranial nerve. I'll always find ways to test on it through semesters. So parasympathetic tone, muscarinic receptors, bronchoconstriction. Cool. Other things. Leukotrienes, this is basically another immune response function. I tend not to talk as much about leukotrienes. They're super cool. They're definitely important, but you guys already have enough to learn. So I like to focus you guys on things that we've seen before. Histamine. We talked about histamine when we were talking about blood. And now we're going to talk about it again here. Histamine is released from basophils during an inflammatory process. Histamine is also secreted from a cell called a mast cell, which is part of an immune response. And so if you have an allergic reaction, your immune response goes crazy and your inflammatory response goes crazy. And histamine starts being secreted by these cells. Well, look what histamine starts to do to the bronchioles. It causes bronchoconstriction. So now somebody's having an anaphylactic shock reaction, too much histamine is being released through their body, and those bronchioles collapse. You guys all probably can follow what I just said there. Now you can give that patient an antihistamine, and that's going to block the amount of histamine in the system, and that should help fix those bronchioles over time, but that's not an immediate response. What if their lungs have completely shut down? What if their bronchioles have totally collapsed? An antihistamine is not going to fix that problem right now. We need that problem fixed in the next 15 seconds to 2 minutes, right? So what do those people carry around on them? What are those people that know that they're highly allergic to bees, highly allergic to a food? What do they always have? You guys are already writing it in chat. This is an EpiPen. So what is inside of an EpiPen? Pure epinephrine. Okay, that's exactly what we need. We need a counter to the bronchoconstriction. So we give them straight epinephrine, causes massive bronchodilation, and that patient can breathe again. We still got to get rid of that anaphylactic shock, but at least they can breathe. Does that make sense? I forgot I had this slide. I just used this entire slide for this, but yeah, this slide's the same idea. Airway resistance is primarily controlled by parasympathetic and sympathetic, but the sympathetic function, bronchodilation, this is norepinephrine, epinephrine released as a form of adrenaline. So this is only emergencies, really. We don't get massive bronchodilation due to sympathetic activation. Rather, we just change the tone of parasympathetic. We can increase the amount of acetylcholine or we can decrease the amount of acetylcholine. And that in and of itself will change the diameter of those airways. Make sense? There is more that's involved. Of course, there's always more, and there's always more. I love this table, though. This kind of tries to tie everything we just discussed together. Bronchoconstriction, bronchodilation, just changing radiuses and therefore changing resistances. This is a really cool table because check it out. Bronchoconstriction, we go through pathological factors. So what pathos can cause broncho? Well, there's your allergies. There's your histamines and your leukotrienes. What pathos can cause bronchoconstriction? Well, physical blockage. Okay, anything that might cause that airway to get smaller in diameter, whether it's just snot or that airway collapses. And then physiological. So this is normal everyday life. Physiological factors, parasympathetic nervous system, and CO2. Even though I didn't discuss it up here, CO2, it's going to be doing the opposite of what it does here. So if we have too little CO2 in the system, as we drop CO2 that's in the system, well, we don't need to get rid of that CO2 as fast. So we don't need to have nice big pipes to help us get rid of that CO2. I absolutely love this. Bronchodilation. Pathological factors that make you breathe better. None. I suppose there could be one that make you bronchodilate, like if you had pheochromocytoma, if you had a cancer of your adrenal medulla that causes you to secrete excess epinephrine. Well, now all of a sudden your airway passageways are going to be bigger in diameter. But, you know, most likely there's not going to be very many pathological factors that cause bronchodilation. Cracks me up. Whereas physiological factors, sympathetic stimulation, why does that have a minimal effect? Why would neural control, sympathetic stimulation, have a minimal effect? What did we just say? What did we just walk through? Why would it have a minimal effect? Why would innervation, neurotransmitters, why would this have a minimal effect? And actually, that's actually a good thought. I never really kind of went down that road. Right? No receptors. I say what makes a target cell, the presence of receptors. But in this case, it's not about the receptors, because there are receptors there. They're beta 2 receptors. And norepinephrine and epinephrine can activate beta 2s. But in this particular case, if there's no synapse, if there's no nerve that's sending its axon down to those beta 2s, then activating the nervous system control isn't going to have a very big impact on bronchodilation. Does that make sense? I liked your answer a lot. It's just not accurate because this isn't about the receptor. There are receptors here. But neural control, minimal, hormonal control, massive. So we get a burst of epinephrine. It will cause bronchodilation. But the largest control of bronchodilation is CO2. Now, if you go back to this original slide, I said the resistance of the airways were, related to all three of these. And now we're going to come back to these other factors in just a second. Well, just a second turned out to be 20 minutes later. But resistance in your lungs is not only related to the length, the viscosity, and the radius. Of course, right? That would make it way too easy. Resistance in the lungs is going to be primarily determined by one, the diameter of those tubes, which is what we just did over here. We just spent a bunch of time on. So you better have a basic understanding not only of this whole synapse and innervation point, but parasympathetic control, histamines, CO2, that sort of stuff. So the diameter of those tubes, well, these are going to be controlled by both intrinsic and extrinsic controls. Intrinsic controls of the diameter. Even though I didn't specifically say it over here, I hope you guys start to think about CO2. This is a local control. Therefore, that's an intrinsic control. Does that make sense? Extrinsic control is going to be nervous system and the endocrine system, like with epinephrine. So I hope those words, are starting to resonate because we see them in every single unit. But there are two other variables that are involved in the resistance of your lungs. Elasticity. Elasticity, this ability to recoil, but to also stretch first, because things that are elastic are compliant. Things that are elastic will stretch, and then they'll recoil. But what if we lose that elasticity? What's going to start happening to the resistance of those airways as they're no longer recoiling or potentially even stretching, by the way? Exactly. COPD, right? All the different types of COPD that are out there. If we decrease the elasticity of our lungs, we're going to have to create more pressure in order to keep those lungs, one, inflated, and two, as we breathe, the resistance of the loss of that elasticity is going to make us have to produce even more pressure to fight against that resistance. So elasticity plays a really big role in resistance. The elasticity is all about, if I have elastic fibers, I can stretch them. Remember, the word for stretching is compliance, and a rubber band can stretch. The more compliant it is, the easier it is to stretch those lungs. And as we start to lose that compliance, as we start to lose the elasticity, we will lose that compliance. What's going to happen to your ability to stretch your lungs? Increase, decrease, no change. I love this image over here. This is immunofluorescence of elastic fibers. Look at how much elastic fibers. How much elastic. That's all these tiny little green lines throughout here. That's all elastic fibers. I mean, it's literally, you know, that, let's go see the world's largest rubber band ball, you know, ball of rubber band. That's what I think about when I think about our alveoli. Each alveolus is surrounded by these elastic fibers. But what starts happening in some diseases is that the elastic fibers start turning into collagen. And collagen, whether you were taught this or not, is crazy, crazy, crazy strong. Collagen, at its given size, if you pull on collagen and if you pull on a piece of steel that's the same size of that collagen, the steel breaks first. Collagen has greater tensile strength than steel, and our body makes it. It is a powerful, powerful rope. And if we start replacing elastic fibers with collagen, what just happened to the compliance, the ability to stretch that fiber, those tissues out? Oh my gosh, it plummets. Okay, different types of fibrotic lung diseases are going to cause that. Different types of COPD can cause this. That's exactly what scar tissue is. Good, exactly, Heather. It's just collagen. The second part of what can cause poorly compliant lungs, I'm going to deal with in just a second. But it has to do with this chemical called surfactant. And I mentioned surfactant yesterday. I said we'd come back to it today, and we're almost there. In fact, let's go ahead and get there. Because the last factor that's involved in the flow of air has to do with the fact that those alveoli are always trying to collapse. If they're surrounded by elastic fibers, then these tiny little balls, each individual one, is trying to collapse on itself. Does that make sense? Just take a balloon and pop it. Right? It's going to collapse. Well, we don't want that. So we got to come up with a way so that our lungs don't collapse. And this is via a chemical called surfactant. And it's those type 2 alveolar cells that produce that surfactant. Right? So surfactant is going to be that last variable that controls the resistance. Okay, these are secreted by type 2 alveolar cells. And what surfactant is, in essence, it's a phospholipid. It's a type of phospholipid. Okay, so surfactant has one side of the molecule that is polar, and the other side of that molecule is nonpolar. Huh. One side's polar, one side's nonpolar. I got one side that is attracted to water. Yes, no? Up here is polar. Therefore, it is water soluble. And down here on the other side, I have nonpolar, so it's lipid soluble. Which side will be attracted to water? Only that polar side. Okay, make sense so far? Why is surfactant important? Why do our lungs need this stuff? Well, we're going to draw this all in. But first, I want you guys to think about a balloon. These good old balloon analogies. I want you guys to think about a balloon where the inside wall gets wet. Now, I'm talking water. Okay, the inside of that balloon gets wet with water. What would happen if those walls were to come into contact with one another? This is just like my two pieces of paper with water in between them. They're going to stick together. They're going to have surface tension. Do we want surface tension inside of our alveoli? Does that sound good? No. This would cause alveolar collapse, and now we got to try to breathe, force air into our lungs to blow that balloon back up. And if you've ever tried to, great analogy. Anybody ever given a balloon to a kid and had them try to blow it up? Then oh, I'm so sorry. Yeah. We'll go into that respiratory distress syndrome, but that's cool that I know somebody in the class had it. But anyways, that you ever tried to give a balloon to like a 4-year-old, 5-year-old kid and had them try to blow it up? They just spit into it. You guys know? And then they give it to you to try to blow it up, and it makes it so damn hard because those walls are wet and you got to put extra force to get it to blow up, because you got to get rid of that surface tension first. You got to break those walls apart from one another. You guys see what I'm saying? So your body would be the same way. If your alveoli were to collapse, you would have to force more air. You'd have to have stronger ventilation. You'd have to have a stronger pressure gradient to be able to still blow those alveoli up with air. Does that make sense? Cool. There's some other real life scenarios now that start coming into play, but we'll come back to that in just a second. So what we have in place, if I just had an alveolus, I'm not going to draw it open, I'm just going to basically draw a circle, and I coated this with water, well, that would be bad, right? This is going to end up causing surface tension between these walls. That would be bad. No bueno. Surface tension would cause that alveolus to collapse. So what do we do instead? Well, we take that same alveolus, and now we start throwing a chemical called surfactant in there. And I still have a border, a really thin border of water, very, very, very thin border of water. Okay, this very thin border of water. It exists. Everybody's alveolus, because there's moisture, there's mucus, it's 100% humidity. There's gonna be some water down here. Not much we can do about it. But now I take surfactant and I start to secrete it in here. This is basically a phospholipid. One side's polar, one side's nonpolar. So what side of this surfactant is going to be attracted to the water that's on the surface of your alveoli? The polar side. And the nonpolar legs, they hang out here, which is great because what's out here in the middle of your alveolus is oxygen. And oxygen's nonpolar. And so now these little legs say, hi, oxygen, how are you? See what I'm saying? Water on one side, nonpolar on the other side. We got a nice happy story, and these line up, right? And they go all the way around. I'm going to show you guys a picture, not that I draw. But now what ends up happening is we get rid of the water. If we completely coat this with surfactant, the water is no longer going to be attracted to the water on the other walls. If you line this all the way up and around, you got a polar side that's attracted to the water side, and you got a nonpolar side that's attracted to the airspace, and that's going to keep this lung, this alveolus, from collapsing. So short and sweet, It's short and sweet. Kind of. I just want to make sure you guys learn how things work. I can just spew this out in 10 minutes, but then you're not learning. The short and sweet of surfactant is that the whole function of surfactant is to reduce or decrease the surface tension. That's easy in and of itself to learn. Decreases that surface tension. But how does it decrease that surface tension? That's related to its chemistry. And here's a cool thought process, is that you actually have surfactant in a common household chemical. And I want you guys, before break here, anybody want to guess what is that common household chemical that has surfactant in it? A form of surfactant. It's not the same as what your body produces here. Yeah, it's soap, and it's mostly exactly what you guys are writing. It's dish soap. Most of you guys aren't old. You don't go back too many years, and there used to be lots of commercials like in the 80s and 90s on running your dishwasher, and your dishes always used to come out with water spots on them everywhere. I don't know if you guys remember this, if any of you are old enough to remember this, but dishes used to come out with water spots on them all the time. And the reason why is because when you clean a dish in regular soap and you wash it with water and stuff, what ends up happening is that certain areas of that dish continue to have surface tension, and even though it's clean, water clings to it, and then when it dries, it gets a water spot. So that used to happen in dishes all the time. So what they started to do is they add surfactant, a synthetic surfactant, to that dish soap, to that dishwasher soap, and it prevents those dishes from getting water spots anymore, because surfactant is soap. It's just a type of soap that your lungs are producing. And now we can have a surfactant that clings to the dish, prevents the water from binding to that dish when it all is said and done. And therefore you don't get water spots. Okay, last bit of information here in terms of pathos, because I want to get back to this respiratory distress syndrome, is that surfactant is a tricky one in terms of fetal development. Are you breathing inside mama's belly? You're not in her belly, but it's a fun thing to say to 4-year-olds. You're not breathing in there. You don't need to breathe. Where do you get your oxygen from? Get it from mama bear. Where do you get rid of your CO2? You throw it through mama bear, right? So mama bear is taking care of all your stuff, including your poop and your pee. Congratulations, moms. So you don't need to breathe if you are a fetus. Mom does all that work for you. So we don't need to start producing surfactant until pretty darn late in fetal development. Does that make sense? That it's going to be one of the last things that's developed as you are going through this fetal development. And the reality is that surfactant doesn't really start getting produced in force until, 32, 34 weeks of fetal development. So pretty late in gestation. Kids are born, around anywhere between 38 to 41 weeks. That's a long time to carry. You mama bears are so amazing. It's just crazy. So kids are normally born around 38 weeks, and the surfactant starts being produced around 34 weeks. Plenty of time, right? Now we got surfactant inside those lungs. Great. But what happens if you come out early? What if you're a preemie baby? It's one of the big complications in a preemie. If you're a preemie, you're coming out and your body hasn't fully started to produce surfactant. Some preemies are coming out at 26, 27 weeks, and they haven't even started producing any surfactant at all. So what do we know about those preemies? Are they breathing really good or are they breathing really bad? They have respiratory distress, massive. They can barely breathe. They are trying to breathe, but they're having to force these massive pressure gradients just to open up those alveoli against all that surface tension. Does that make sense? So Melissa, what did they do? What did they do to you? And I don't know, I'm sure you remember, you know. But what did they do? What did they do for these babies? Anybody want to guess? We just let them go? Steroids, good. Ventilator, great. Exactly. So they're actually going to put them in a ventilated chamber right off the bat. Definitely some steroids are going to come into play. Those steroids are going to help to basically, there's different sorts of beta 2 adrenergic activators and stuff like that that are involved. One of the big ones is they get them in a ventilated chamber. I mean, it's bad for some preemies. They come out and mom never gets to hold them, right? There's no connection there at all at the early stages because they're basically in a box. They're basically in a box. I mean, I guess I shouldn't. There's no negative there because at least that baby's alive and mama's going to be able to get them. So you came out 28 weeks? Absolutely. But other things they can do are things like nitric oxide, beta 2 adrenergic agonists like albuterol. And guess what? What did I just tell you? What's the story I just told you about dish soap? Dish soap has surfactant in it. We can synthetically make surfactant, and we can actually get that surfactant into that fetus's lungs now. Well, I guess not a fetus anymore, right? That infant's lungs now. Sorry, that was a slip of the tongue. And we can put small levels of synthetic surfactant into their lungs, and it starts to coat those lungs and helps them breathe better. They're still going to need to be on a ventilator, though. Make sense? You're not wrong, Veronica, about steroids. We're going to give them a cortisone injection, typically, anti-inflammatory, that starts to kind of increase the airway passageways. So we're not directly affecting the alveoli, but we are definitely impacting how much air can get in and out of their lungs, trying to help with that gradient. All right, everybody cool? Everybody kind of have an idea of not just the physiology, but some of the ways that can go wrong? Of course, this is not a patho class. Again, we just use the to understand the physiology better. Yes, no, maybe so? Cool. All right, let's take a break. Please be back. What is today here? Today's Wednesday already. Biscuit eater. Okay, we got some things to do. All right. Still, I always like to give you guys a good break. So 45, 45, 50. Let's go 50 after. So in 22 minutes. Be prepared to get rolling because we got some things to go through. All right, welcome back. Welcome back, welcome back, welcome back. Hi. All right. So, just a couple things that we're going to do via sharing. Can't tell you how many times I've started to talk in the past and not shared my screen, and I'll go like minutes, and then students will finally be like, Dr. H, can't see your screen. Are you writing something right now? Dang it! Gotta go all the way back. Okay. Let's go here. That's funny, Melissa. I got it. Let's just remind ourselves the 4 processes of the respiratory system, because it's what we do, right? It's all about redundancy. So the first process we just spent a whole bunch of time on, it's ventilation. We can go ahead and write the formula down for ventilation, but I'm not going to. You guys can figure all that out on your own. We've done that plenty of times. Now, once we get down into the lungs, we have air inside of the alveoli. Now we get to have gas exchange. It's not until this point that we have gas exchange. And we have to think about the structures that determine the functions as we do this. We know that it's occurring inside of the alveoli, between the alveoli and the pulmonary capillaries. This is alveolar respiration, right? That's what respiration means. It means gas exchange. Sweet. Easy peasy lemon squeezy. And as we go and try to think of the anatomy, the structure that determines the physiology, determines the function, the easiest way to go about doing this is to remember Fick's law. Fick's law helps us understand everything, I think, in just this really nice synergistic way, where Fick's law is all about diffusion. Since we are dealing with oxygen and CO2 here, gas exchange, we're dealing with nonpolar objects, and nonpolar objects can pass through cell membranes. Therefore, they rely on passive diffusion, and passive diffusion has a speed associated with it. That's what Fick's law is helping us understand, is that there is a rate that things can diffuse. There's a rate of diffusion. We've done this. The number one thing that determines whether diffusion exists or not is simply the gradient. If there's a gradient, things will move. They're going to be trying to go from high to low. And the more surface that whatever it is we're talking about, the more surface that it has to move, the faster it can move. Last but not least, depending on its membrane permeability, this is kind of referring to both the membrane itself and the chemical. Depending on its membrane permeability, its diffusion rate will go up as well or down. The more polar it is, for instance, diffusion starts to drop. The more nonpolar it is and the smaller it is, diffusion is going to be increasing. And this is all related to the distance it has to travel. This is the most powerful, therefore we give it a power. Even though a gradient is required. Anything on the top, if it's 0, there is no diffusion. But as long as there is a value in every one of these upper spots, we're not at 0, right? Then distance is going to play a huge role in how well things can diffuse. So now let's start thinking about the structures of our alveoli that come into play for respiration. So give me one of these variables and tell me something about it. Any of these variables, say surface area, blah, 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 blah. Why does the structure of the lungs promote so much diffusion? What do we know about the membrane permeability? Well, what about the chemical? What do we know about the distance it has to travel? What about the structures of the alveoli? People just kind of write it down Love it. Melissa, exactly. So that super large surface area of the lungs, each lung is about a tennis court of surface area. It's going to promote the rate of diffusion. And as that surface area drops for any reason, whether it's a disease like even pneumonia, can start to decrease the available surface area, or emphysema, or removal of a portion of the lung due to lung cancer. All of those can impact that surface area. Somebody else. All of these variables can be impacted. Lovely, Ashley. Let's see. If a liquid on the membrane increases the distance, nice, and decreases the rate of diffusion. That is going to be a patho, which I definitely want you guys thinking about. But quickly, who can tell me what about the normal physiology? What about this distance is so wonderful to help with the rate of diffusion of oxygen? Is this distance normally really far, or really, 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 really short? Small or big? Small or big? What do we know about the structures of the system? So what do you guys know about those structures? What sort of structures in our body? Because remember, everything's built from the molecular level, cellular level, up to the tissue level. When we really want to be thinking about our organs, and when we want to be thinking about physiology, oddly enough, it all happens at the tissue/cellular level. So we got to be able to think about those tissues. So what about the tissues is promoting this distance? Thin epithelium. What type of epithelium, Becca? Good. Simple squamous epithelial tissue. Is everybody on board with that, whether you were the first to type or you never typed? Does that make sense? Now, let's not forget that still needs to diffuse into the blood. It still needs to diffuse into the blood, too. I have this open somewhere already. It still needs to diffuse into the blood, but what about the anatomy of the blood is also promoting diffusion? Well, it's the thinness of the capillaries. Yes, no, maybe so? The capillary epithelial tissue is simple squamous. The alveolar epithelial tissue is simple squamous, and they are fused together by a single basement membrane. This is very, very unique to your lungs. Most of the times, there'd be a lot of connective tissue in between a cell and your blood, but there's no interstitial fluid here at all, basically, right? It's just a basement membrane, a basal layer, that's fusing one cell to the next cell. Pretty cool. And it definitely, the anatomy of the system, this respiratory membrane, is absolutely promoting the rate of diffusion. Yes, no? The hairnet. Oh, that is capillary beds and then the elastic fibers. Cool. So there's still one more variable that we kind of need to talk about in terms of alveolar respiration. This is the variable that must exist, is a gradient, must exist. So this takes us back to, I want to draw it over here so I have room to finish this chart off over here. This takes us back to Dalton's law. And Dalton's law is the one that goes through and describes that each gas, each molecule, applies its own pressure in the atmosphere. And according to Dalton's law, the total atmospheric pressure is what? (760 millimeters of mercury). But of that, what percent of the air is made up of oxygen? And if we take and do the math and we say 21% of 760, then the atmospheric partial pressure of oxygen, which is what we care about, is approximately 160 millimeters of mercury. And that's good enough for y'all to learn. It's actually slightly smaller than that, but we don't care. This is in the atmosphere. There's going to be a step here that's a little complicated. So we're going to kind of skip the idea of this step for just a second. And I want you guys to now go, what do we know about the partial pressure of oxygen inside of the body? Is it going to be greater than or less than 160 millimeters of mercury? So there's a couple of different answers now. Okay, most people are getting less. That's awesome. Let's not forget, and this goes for everybody, because I got 4 people that answered out of 18. I'd love more people to be answering this. Let's never forget high to low. I think I mentioned that so many times this semester to try to help you. It's going to help in every single system, whether it's digestive, respiratory, cardio, or renal. It doesn't matter. Repro is one of the few places where we don't talk about it much. High to low. We got to have high to low. In order for diffusion to occur, it's got to go from high to low. That gradient sending it from high to low. So if I want to get oxygen into my body, and the atmospheric partial pressure of oxygen is 160, do we ever want this number inside of our body? There'd be no gradient. Therefore, there'd be no diffusion, whether we're breathing or not. Does that make sense? What if the number inside of our body is greater than 160? Well, then oxygen's leaving our body. We don't want that. So the logic would imply that the pressures inside of our body have to be lower than 160. True story? Everybody breathe in. You just breathed in oxygenated air. Everybody breathe out. You just breathed out CO2 rich air. But everybody, one of those. Oh, well, yeah, we'll talk about that, Heather. Yeah, that's exactly why we have oxygen bars. Let's everybody breathe out though. Were you able to get all of that CO2 out of your conduction system? Or is there something left over in there? Crazy to think about, and I know it took me a while to really just start to focusing on that. But as you breathe out, there's always going to be some volume of air left inside of your trachea, bronchi, bronchioles, even up in the nasal cavity that is carbon dioxide rich. Yeah, but this isn't necessarily good leftover, Tariq, because this is carbon dioxide rich. So everybody breathe back in. We're pulling all of that CO2 back into our system again. It's mixing with oxygen-rich air. Yes, no? Yeah, I like it though, Tariq. It's a good place for you to reference that there's always something left over. Good. Yeah, so this is called dead air. Literally, that's what it's called, is dead air. And what's happening in dead air is it's CO2 rich. So as we breathe in, what's going to happen to the 160 millimeters of mercury is it's going to be mixing with carbon dioxide rich air. Yes? Dead air. So what's going to happen to this number, 160, as it mixes with dead air? Increase, decrease, no change. That makes sense? It's mixing with other air, which dilutes out the oxygen, and that number is going to drop. So the partial pressure of oxygen, the PO2, but now we're talking about inside of the alveoli, it's going to be lower than 160 because it's mixing with CO2. And it's going to drop. It's going to drop to a decent number. It's going down to about 104 millimeters of mercury. It's a pretty big deal. This is all happening just during ventilation. We're losing oxygen because it's mixing with CO2. Yeah, dead air is inside of the conduction system. It's inside of your trachea, your bronchi, your bronchioles, nasal cavity, your pharynx. It's air that's left over as you've been breathing out. We'll come back to it later. I just want to make sure you guys see that oxygen's mixing with CO2, which is going to cause that partial pressure to drop. Now, next, as blood is returning to the right side of the heart, is it oxygenated or poorly oxygenated? And as it leaves, poorly, yeah, never mind. I love it, Andy. And as it leaves the right side of the heart, it's still poorly oxygenated and it goes out to the lungs. True story? Everybody with me on this so far? Poorly oxygenated air tells us that there's not a lot of oxygen in here. So how much oxygen is actually left? As it's returning to the lungs, we're going to have a value that's relatively low. Okay? Just depends on the metabolism of the body, but we're going to have a value that's less than about 40 millimeters of mercury. This is the partial pressure of our venous return. Okay, this is poorly oxygenated air. This is the venous return to the right side of the heart. And then from the right side of the heart, of course, it's pulmonary arterial return. So this is pulmonary arteries. So I'm going to go pull A, partial pressure of oxygen, is less than 40 millimeters of mercury. Is everybody with me on these numbers right now? So the way this looks is as follows. Air is going from the atmosphere, we breathe it in, and it enters our pulmonary circuit, right? It's not going in the pulmonary circuit yet, sorry. It enters our alveoli. So now we are here in our alveolus. What do we know about the partial pressure of oxygen inside of our alveoli? It's about 104 millimeters of mercury. So where does oxygen want to go? It wants to go from an area of high to an area of low. So now oxygen wants to diffuse to wherever it is lower. Does that make sense? It's going to diffuse towards that 40 millimeters of mercury. So as blood leaves the right side of the heart, passes out into the lungs, the beginning of these pulmonary capillary beds is going to be approximately 40 millimeters of mercury for the partial pressure of oxygen. But now, as oxygen moves from the alveolus into the blood, what's going to be happening to the partial pressure of oxygen this entire time? As oxygen moves from the alveolus, alveoli, into the blood, what's going to be happening to the partial pressure of oxygen? Increase, decrease, no change. Okay, let's just stop for a second, because definitely not drops, which is okay. Let's think about this logically. Poorly oxygenated blood is leaving the right side of the heart. What's going back to the left side of the heart? Oxygenated blood or poorly oxygenated blood? Maybe, Heather, you were thinking about what's happening inside the alveolus, but I'm asking what's happening inside of the blood. So we know oxygenated blood is going to return to the left side of the heart. So what's happening to the partial pressure of oxygen inside of that blood as it passes through the pulmonary artery? Is it increasing or decreasing? There we go. Does that make sense? And when is 104 going to stop diffusing? 104 is going to diffuse until, when does diffusion ever stop? 1 104, but the words that I'm looking for, Ruju, is equilibrium. Awesome. Until we lose that gradient. You're not wrong, Ruju, until the blood turns 104. Perfect? Makes sense? So in our drawing down here, we don't get all this pretty capillary stuff in here. That's fine. That's fine. We're going to have 40 millimeters of mercury of blood for partial pressure of oxygen entering the lungs. But what's going to be leaving the lungs? Approximately 104 millimeters of mercury of blood. Does that make sense? Now, it never actually reaches 104. It's never going to make it to equilibrium. There's a number of variables involved in why. I'm not going to go about explaining why. But as this blood, poorly oxygenated blood, travels through the lungs, it's going to pick up oxygen. It's going to be traveling from 104 down into the blood, and then it returns that blood to the left side of that heart. Then the left side of the heart pumps it out to the systemic circuit. Well, the approximate value at this point, it should be in the blood about 104, but it never really makes it that high. So the pulmonary veins, the partial pressure of oxygen out here is about 100 millimeters of mercury, not 104. It's about 100. And this is not a bad thing, because this keeps a constant pressure gradient. There's always 104, even moving towards that 100. I'm going to go through why it makes it to 100 and then stops. But you guys see 104 is moving towards 40 until we reach 100. A lot of students always, every semester, they're like, what's going on here? I just described it in detail. 40 millimeters of mercury is entering, poorly oxygenated blood gets oxygenated. So 104 is moving towards that 40 until we reach 100. Now, no blood really is picked up anymore, right? We don't have lungs in the heart. So we make it to the heart, the value for the partial pressure of oxygen doesn't really change. Not a lot of blood ends up getting pumped off to the heart. So the partial pressure of oxygen throughout the systemic circuit is pretty consistent. So if I'm out here looking at systemic arteries, the partial pressure of oxygen out here remains about 100 millimeters of mercury. Blood's not really removing oxygen until it gets to the tissues. Now, that tissue could be on the surface of the heart, or the tissue could be in the brain. This systemic artery is going to a tissue. You don't know which tissue it is. It doesn't really matter. But what's going to end up happening is that systemic artery is going to lead to a capillary bed. Yes, no? So down here, we're going to have capillaries. This blood is going to flow by this capillary bed, and the capillary bed is going to lead to cells down below. So I have a blood supply that's passing by, I don't know, we'll just draw in a few simple cuboidal cells. That's easy enough. Okay, so we'll have some nuclei in here. Great. So this oxygenated blood is traveling by this cell. It's in the capillaries, so it's going to have to leave the capillaries to go into that cell. So what do we know about the partial pressure of oxygen inside of this cell relative to the systemic arterial partial pressure of oxygen? If I want to move this oxygen from here to here, is it going to be increase, decrease, no change? The L's always trip me up in chat because I think they look like I's because it's a lowercase L. It's like, no, oh, they're not saying that. right? So what's going to happen to the partial pressure of oxygen inside of these cells? Increase, decrease, no change relative to arterial. Now we know this, right? Because we know oxygen needs to move from high to low. Yes, no, maybe so? Lovely, 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 lovely. How do we keep the oxygen? Well, let's ask another question first. When would oxygen stop moving from the blood into this cell? When would it ever stop? If it made it to equilibrium. Is it ever going to make it to equilibrium? Are we ever going to get 100 millimeters of mercury out here in the cells? Why not? What are the cells doing to that oxygen this whole time? I love that you wrote BB, whether or not you intended that or not. Yeah, it's going through cellular respiration, isn't it? So what do we know about cellular respiration? Oxygen plus glucose plus some ADPs and some inorganic phosphates. A little bit of shake and bake. And the byproduct is ATP. Magic. But there's some other metabolic waste. What other metabolic waste do we got out there? Oh no, we're building up some CO2 here. Okay, we're gonna have to do something about that. And then some water, which is important as well. We will come back and talk a lot more about water. It's stupidly important. How are we gonna get oxygen from the pulmonary circuit down into these cells? I need to transport it through the blood supply. Oxygen and CO2 are both non-polar. So step 3 for my respiratory processes is transportation. Does that make sense? So how does oxygen get transported? Well, we know that oxygen is nonpolar. It's very nonpolar. And the more nonpolar it is, the less it can dissolve in water. Now, even oil can dissolve a little bit in water. It's just not a whole heck of a lot. Even oxygen can dissolve in water. So as oxygen enters the blood from the alveolus way up here, as oxygen enters the blood, there's still going to be a very small amount of that oxygen that dissolves. It's a very small number, though. Only about 2% of oxygen dissolves. That's going to dissolve in the plasma. But the rest of this needs if it's nonpolar and it needs to get through the bloodstream, what does it need to get through that bloodstream? It needs its Uber system. And what is the Uber system for oxygen? It's hemoglobin. So the other 98% of oxygen binds to hemoglobin, or more specific, it binds to the heme group. More specifically, it binds to the iron on hemoglobin. Trillions and trillions of hemoglobin in the human body for binding up O2. 98% of oxygen can bind to it. But you only have so many heme groups. And at some point, that oxygen bound to those heme groups is going to saturate. You won't have any more heme groups available. Does that make sense? This is why our blood never makes it to 104 millimeters of mercury. It makes it up to about 100 millimeters of mercury, because at that point, your hemoglobin is saturated. You basically don't have any more hemoglobin left over to take more oxygen in. Does that make sense? 100 is about the maximum. Can it change between patient to patient? Of course. This is just an average. Sound good? But it's a pretty consistent average. Humans in general tend to have pretty consistent around 100 millimeters of mercury of partial pressure of oxygen in their bloodstream. Now, we transport that oxygen down to the tissues. Now, why does oxygen leave the blood to go into the tissues? Well, that's that fourth process down here. Does this make sense? The fourth process down here is cellular respiration. And let's just because we can, let's just because we can write this equation down yet again. If I'm going to be talking about cellular respiration, if I'm going to be talking about gas exchange, the reason why we have gas exchange is because oxygen in the presence of glucose and ADP and inorganic phosphate, mitochondria do their thing for aerobic oxidation, we're going to be producing ATP. But a big deal down here is what comes next. I'm not doing this for my own health. I'm not doing this just to annoy you guys. CO2 and water is a big deal. CO2 and water is a big deal. Did anybody do that basic science chem test back in high school or even middle school? I think I did it back in middle school, where your teacher has you just blow into water through a straw. Just blow. And you take litmus paper and you just test the acidity of that water. Well, what's happening is as you blow out, you're blowing out CO2. And as CO2 reacts with water, a chemical reaction occurs. In the human body, the chemical reaction is going to occur faster due to an enzyme you guys are going to learn about. But CO2 and water, I'm going to take and combine these two molecules. This is exactly what happens. We get a chemical reaction between CO2 and water. CO2, we got to think about these guys separately, and water. Those are going to have another shake and bake, one of their own. This shake and bake, just like everything in the body, is controlled by an enzyme, so we'll come back to what that enzyme is. This can happen with or without the enzyme, but enzymes catalyze reactions. They reduce the energy required for a chemical reaction to occur, therefore the chemical reaction is more likely to occur. I hope that made sense. So even if you blow through a straw, that water doesn't have the enzyme, but the chemical reaction can still occur if there's enough CO2. Does that make sense? Okay, so what is this chemical reaction? Let's take and add all of this stuff together. How many total hydrogens do you guys see here? So we're going to, there's two, H2. You're all right. H2, so there's two hydrogens, so we're going to keep that consistent. There's two hydrogens. How many carbons do you see here? And now how many oxygens do you guys see here? H2CO3 is what is produced. H2CO3. Well, what is this? This is a chemical called carbonic acid. This is the most important acid in the human body by a long shot. As CO2 mixes with water, it creates acid. What do we know about an acid? what is the definition of an acid? Since sometimes I think students really have trouble with acids because all they know is the definition. They don't actually think, because they weren't taught, how it applies. What is an acid? Okay, we got different answers. Love, Sabrina, thanks for speaking up. That's actually a really important difference that we're going to be learning about, Sabrina. Awesome. Definitely not lower pH than 7 per se either, although you're not wrong, but that's not what an acid is. Ashley, that's its function. There we go. Definition. It's a proton donor. Electron acceptor. It's an electron donor, but still good. I like that you guys are electron acceptor, H plus, electron. No, it is. Yeah, but we don't end up using that terminology very often. Now, there's a big difference between an acid and acidity. So Sabrina and Becca, you guys are talking about acidity. And acidity is the number of acids. Acidity is the number of acids, of hydrogens in a solution. Less than 7 pH is acidic, but it's nothing to do with an, I shouldn't say that, but it's not the same thing as an acid. This will make more sense. Let me get through this. Acidity is the number of hydrogens in the solution. It's not an acid. An acid is something that can donate a hydrogen. That's the easiest way to understand an acid. There are other definitions of acids, and acids can become a lot more complex. Not all acids. There are other ways that we can get acidic solutions besides an acid. But an acid is something that donates a hydrogen. I don't want to get into the rest of that. Donates a hydrogen. That's something we know about acids. And hydrogens are bad because they break down proteins. Hydrogens are bad, Ashley, because they denature proteins. They break them down. They cook them. All right. But what do we know about carbonic acid is it's going to donate a hydrogen. Huh? Let's take this molecule right here, carbonic acid, and let's donate a hydrogen. Let's remove a hydrogen from this. What's left? H, we've lost that hydrogen. CO3. But an important part of that, Andy, is we just lost a hydrogen. And what charge just went away with this hydrogen, y'all? What charge left with the hydrogen? A positive charge. So what's going to be left over? If I lose a positive charge, I become slightly more negative. HCO3 negative. In AP1, I hope, you guys were taught a list of very important ions in the human body. An ion is a charged particle. Sodium, potassium, chloride, calcium, hydrogens, phosphate, and bicarbonate. This is bicarbonate right here. Okay, this that was just created is bicarbonate. This is a bicarbonate ion. Anybody ever heard of a bicarb before? Ion here. Where you guys heard of bicarbs? What sort of places do we find bicarbonates? We'll come back a lot more to this later this semester. I just want you guys to start thinking about this bicarb ion right now. In Chem Lab, cool. It's one of the most important buffers. Aha! Baking soda. Love it. Baking soda is just bicarb. It's a sodium bicarb. So that's it. That's what it is. Sodium ion, which is an Na plus, just bound with an HCO3, right? So I have one ion that has an ionic bond with another ion. That's exactly what's going on in acids. Acids have an ionic bond where one hydrogen is bound to another ion. All acids work that way. It's a kind of a cool way to think about it. So when I break that ionic bond, I remove that hydrogen and I'm left with something that's bound together by a covalent bond. This bicarb is now covalently bound together. This is what Tums is. Tums is calcium bicarb. That's all it is. Calcium bound to a bicarb ion, lots and lots of them. And you eat it when your tummy's upset, right? And it helps to neutralize the acid. Bicarbonate is a buffer. Why? Because if I have a lot of bicarb in the system, that bicarb can now bind up excess hydrogens in the system. And it becomes the most important buffer in the human body. The most important base buffer. The most important base buffer by far. Whereas I said carbonic acid is the most important acid in the human body, but it's actually going to be an acid buffer. We'll talk about more of that later this semester. The reason why these are so damn important is because the body produces a veritable shit ton of carbonic acid. You guys want me to prove it to you? Hold your breath. I'm going to start timing. Hold your breath. Keep holding it. Keep holding it. What's starting to happen? What's your brain telling you to do? Breathe, 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 dummy. Inhale, exhale, breathe. True story. Is everybody, we've done this before, like whether it's a joke or swimming underwater or whatever it is. Why is this? Why is your brain screaming at you to breathe? Everybody stop for a second. If we are not breathing, if we're holding our breath, what's happening to the amount of O2 entering the system? Increase, decrease, no change. But that oxygen's still being consumed by the cells, and it's still making ATP, and the byproduct is CO2. And if we're not able to breathe out, what's happening to the amount of CO2 building up in your bloodstream? Increase, decrease, no change. And like all chemical reactions in the human's body, that CO2, as it builds up, the greater the amount of CO2, the faster this reaction is going to go. CO2 binds to water, lots of water in your plasma, to make carbonic acid. And that acid is building up. It's building up inside your brain. It's building up inside of your blood. And your brain says, oh, hell no. And it's screaming at you to breathe, to get rid of that CO2. Because if we get rid of that CO2, we can't make carbonic acid anymore. Pretty cool, huh? You guys are going to go through this entire process tomorrow. This is partially related to acid-base balance. We lose that acid-base balance when you hold your breath. But right now, we're just trying to talk about the physiology of breathing. Make sense, y'all? These cells are producing CO2. CO2 goes back to that bloodstream. I don't remember what blue color I used, so I'll just use this blue color. So now we got CO2 going out to this bloodstream here. Boom. So is this oxygenated blood, richly oxygenated, or poorly oxygenated blood at this point? It's poorly oxygenated blood. I feel, yeah. Poorly oxygenated blood, which means that the oxygen levels are going to be low. Now, what's going on with the oxygen levels? Well, the oxygen levels in the bloodstream are going to relate to the oxygen consumption in the cells. The greater the oxygen consumption in the cells, the less oxygen is going to be left in the bloodstream afterwards. The oxygen consumption goes up, more oxygen diffuses into those cells, less oxygen will be left over afterwards. True story? And that's why, and we did this up here, that's why this value is less than, it's really less than or equal to 40 millimeters of mercury. It's less than 40 millimeters of mercury because it's variable. That's why we use the less than sign versus the equal sign. This is highly dependent on cellular activity. The greater the cellular demand for oxygen, the less oxygen will be left over. So this value would drop down to 30 millimeters of mercury, 25 millimeters of mercury. Does that make sense? So that less than sign is important. So let's use a brownish color here. And now we know CO2 is being produced. CO2 is being produced and it's getting packed into the cells. Well, the amount of CO2 inside your cells is actually relatively high. Okay, the amount of CO2 inside your cells is high because of cellular respiration. So at the cellular level, the partial pressure of carbon dioxide is greater than 45 millimeters of mercury. So down here at the cellular level, the partial pressure of CO2 is greater than or equal to about 45 millimeters of mercury. Why is it greater than? Why not equal to? Because again, doesn't this depend on cellular metabolism? The greater the cellular metabolism, the more CO2 that cell makes. True story? You consume more oxygen and you make more CO2. So that's why it's greater than 45. This is going to move now into the bloodstream. Until when? It's going to move into the bloodstream until when? When do things stop diffusing? At equilibrium. You got it, right? And so that's why in the bloodstream we have about 45 millimeters of mercury still. We are going to be diffusing CO2 into the bloodstream. So now if we're talking about systemic venules out here and we got a partial pressure of CO2, this is still greater than or equal to 45 millimeters of mercury. It's just going. It's just diffusing as fast as it can. It makes it all the way back up into those pulmonary arteries, and the partial pressure of carbon dioxide is still greater than 45 millimeters of mercury because we haven't gotten rid of any yet. Now, in the lungs, we breathe out. As we breathe out, we get rid of that CO2. Because why? Does anybody remember what that atmospheric partial pressure of carbon dioxide is? I don't know if you look back at your notes yesterday. But the ATM partial pressure of carbon dioxide is crazy, crazy low. It's 0.03%, but the actual partial pressure is 0.25-ish millimeters of mercury. 0.25. 0.2. We got greater than 45 inside the body. This is great, right? Because don't we want carbon dioxide to go from high to low? So inside of the alveoli, the partial pressure of carbon dioxide is a little bit higher because of dead air, but it's still going to be lower than in our blood. And therefore, carbon dioxide can diffuse out of our blood into the alveoli, and we breathe it out. So what's going to happen to that partial pressure of carbon dioxide after we breathe it out? it's going to drop. It's going to go from greater than 45, and it's going to go back down to about 40. Okay, it's not going to drop that much because carbon dioxide's a little bit frisky. We'll talk a little bit more about that. But as CO2 is removed from the blood into the alveoli, that partial pressure of carbon dioxide is going to drop. It only drops to about 40 millimeters of mercury, but this return partial pressure of carbon dioxide is approximately 40. This is going to be equals 40 millimeters of mercury because of the concentration or partial pressure of carbon dioxide in the atmosphere. Goes back through the left side of the heart, nothing's changed. So the partial pressure of carbon dioxide out here is still 40 millimeters of mercury. And when we get 40, that's passing by the cells, 45 or greater than 45 moves towards 40, and we go right back around again. Okay? Let me summarize. Tell me when everybody's ready for a summarization. The partial pressure of oxygen in the atmosphere is about 160 millimeters of mercury. As we breathe in, that oxygen is going to mix with dead air, which contains CO2, dropping the partial pressure of oxygen inside of our alveoli to about 104 millimeters of mercury. Great news, though. 104 is still greater than 40. Therefore, oxygen diffuses into the blood until approximately equilibrium. So the blood leaving the lungs is now oxygenated. It's going to be about 100 millimeters of mercury. 2% of that dissolves, and 98% of that is going to bind to hemoglobin. And it's going to be transported back to the left side of the heart, and the left side of the heart's going to beat it, eject it out to the tissues of the body. It's not until it makes it to those tissues that oxygen starts to diffuse into those cells, because the cells are undergoing cellular respiration. They're using the oxygen. So the partial pressure of oxygen out here in the cells is low. It's very low. It's less than 40 millimeters of mercury. All of this oxygen is going to go pouring into those cells. Therefore, the partial pressure of oxygen in the systemic venous supply, the venous return, is relatively low. Depends on metabolic demand, but it's always going to be less than 40 millimeters of mercury, which now returns back to the lungs, picks up more oxygen, gets back up to about 100 millimeters of mercury, and cycles back around again. At the cellular level, oxygen plus glucose plus ADP plus inorganic phosphates making some ATP, but metabolic waste of that is CO2 and some water. Rut-row. CO2 levels are therefore relatively high in the cells, greater than 45 millimeters of mercury, so CO2 is going to diffuse to an area where it's lower than that. Well, that's the blood. The blood coming in is about 40 millimeters of mercury. So 45, greater than 45, diffuses towards 40 until equilibrium. So that's why the systemic venual partial pressure of carbon dioxide is greater than 45 millimeters of mercury. That 45 makes it all the way back out to the lungs. Lovely. From the pulmonary capillaries, it's going to diffuse out into the alveoli. Breathe it out, dropping the partial pressure of carbon dioxide back down to about 40 millimeters of mercury. And we got a carbon dioxide cycle as well. The only thing that we have left, I hope you guys realize there's a small space here. The only thing that we have left is transportation of carbon dioxide. And I'm not going to cover it completely today. I'm just going to introduce it, and then we're going to stop. You guys are like, thank you, baby Jesus. Yeah, I'm going to stop. I know it's a miracle. But the way we need to get rid of CO2 is it's nonpolar too. It's very nonpolar. But we got a problem. That problem is that CO2 is slightly more dissolvable. So as it enters the blood, because of that carbon group that's on there, it's a little bit less nonpolar. Which means a little bit more is going to dissolve. So approximately 7% of CO2 dissolves in the blood. So that's going to be a small percentage of partial pressure. It's dissolved in the blood. It's dissolved in the plasma. That stuff we can get out of our body pretty easily because it just makes it up to the lungs and is transported out. But here's a big problem. Hemoglobin is not specifically designed to transport massive amounts of CO2. Hemoglobin is about the rotation of oxygen, and we need oxygen bound to this a lot, right? We need it bound to the blood, to the hemoglobin pretty much all the time. We're going to go through saturation and dumping oxygen off, but basically oxygen, there's always a lot of oxygen left on our red blood cells because we need to have that reservoir. So hemoglobin is not as designed to carry CO2. So what ends up happening is only 23% of carbon dioxide binds to hemoglobin. And this time it's actually binding to the globin groups. It's not binding to the heme group. It's actually bigger and it binds to the globin. It's a pretty big difference when it comes down to it, the affinity for CO2 versus oxygen. That only accounts for 30% of CO2 transport. What's happening to the rest? Well, what's happening to the rest is the rest of that CO2 gets converted. What's it getting converted into? What is that right down there? That's carbonic acid. And then what ended up happening to carbonic acid? As long as it's in fluid, which it is, right? Because we have dissociation. If we have dissociation, if you guys remember this from AMP1, the only way that we can break this ionic bond is if we have water in that system. So as long as there's water, which there is, then the hydrogen group enters that water. So does the bicarb. So it gets converted to carbonic acid. We're going to go through this a lot more detail tomorrow. If you guys are freaking out, please don't. We're going to go through it in detail. This carbonic acid is going to get converted to bicarb. Sure, there's going to be an extra acid group out there now, right? An extra hydrogen out there. But the large majority of this is now bicarb. And HCO3 can dissolve in water, no problem. This is extremely polar. It's charged. Yes, no? Does that make sense? I got one yes. Andy says yes. If it's charged, then it's polar. If it's polar, then it can be water soluble. So what happens to the other 70%? Gulp. It gets converted to carbonic acid, then converted to bicarb. It's transported through the bloodstream as bicarb, and back in the lungs, it gets reconverted to carbonic acid, which then reverses its chemical reaction to become carbon dioxide again, which now we can breathe out. Welcome to respiratory system. It's not about oxygen, not alone. It's about oxygen and CO2. 70% is transported as bicarb. It's a pretty big deal. If we start messing with the transportation of bicarb, then we start messing with the amount of CO2 available in our body, and more importantly, we start making acids, and those are no bueno. Let's take a break. Let's take a break.
We will talk more about transportation tomorrow. We're going to talk about oxygen saturation, and we're going to talk about CO2 transport. Everything else we're done with. We're done with ventilation. We're done with alveolar respiration, Fick's law. We're done with cellular respiration, a combination of Fick's law and aerobic oxidation. We will still talk more about this because this equation is going to keep coming back to haunt you if you don't know it. And I'm not just talking about cellular respiration equation now. I'm going to be saying what happens to that CO2? What happens to that CO2? What happens to that CO2? It's going to get converted to carbonic acid. Your body doesn't really have a choice, okay? Because only 7% binds to, sorry, only 7% dissolves, only 23% can bind to those globin groups. The rest, well, shit, we can't have that building up because it's turning into acid. So we need to get it out some other way. Cool, awesome. And then tomorrow we'll finish everything up with nervous system control of respiration. It almost always comes back to the nervous system. As we saw with even the endocrine system, so much of that is controlled by brain function, or unfortunately, the brain can ultimately decide what's going on even with your hormones. Cardio, we always go back to nervous system control, CBCC, that sort of stuff. So now tomorrow we're going to go and talk about the respiratory centers of the brain. Okay, let's take a break. It's lunchtime. We won't make it too long because I like getting you guys out of here, sometime this century. Let's just do a quick 15er. So please be back at 12:15, so I guess 18er. And we're going to go through the lab. Okay. Welcome back. Here. Good, man. Yeah, definitely been noticing you had bad internet today, man. You just keep popping in, popping out, popping in, popping out. So, yeah, sucks. Best of luck. I've never had any internet issues, like ever. Certainly not this summer so far. We lost 5 people. Well, I hope there's at least one person per lab group here. Let's start doing this. So today's lab is supposed to be a respiratory physiology lab. Obviously, we're not going to be there in person, so we can't actually do the physical lab. Now, what is the function? What is the objectives? What were the objectives? Still, what are the objectives of today's lab? Well, we need to start learning some words associated with clinical respiratory diagnoses and whatnot. Basically, clinically, as we're starting to look at somebody's respiratory system, we're going to be using some of these words. Tidal volume, I hope that rings a bell. We already started to describe that today. Inspiratory reserve volume, expiratory reserve volume, vital capacity, residual volume, functional residual capacity, dead space, and total lung capacity. So we're going to be defining each one of these. Now, we're going to primarily be defining it using a graph. Don't worry, that actually makes it easier. I know you guys are like, nah, it does, I promise. We'll break it all down. I'll explain the mechanics of inhalation and exhalation. You guys already know this. This is ventilation. So if you already have this lab printed out, great. But you guys need to understand how ventilation occurs. We're going to have air flowing. We need to have pressure gradients. It's always going to be opposed by resistance. And inhalation is about contracting muscles to change the volume of our chambers. Exhalation is about relaxing or decreasing the volume of our chambers. And that is the mechanics. There's a lot more to it, but that's the simple version. Describe the effects of CO2 in the blood. We're just going to be talking about what we think, what we predict should happen to the respiratory rate and the depth of your breath. That shouldn't be too hard. And then tomorrow in lecture, we'll actually talk about the nervous system, what parts of the brain are involved in this, and how we detect these changes. I hope you guys are noticing it says blood CO2, not blood oxygen. Is that blowing anybody's mind? I know it still blows my mind. Your body cares way more about CO2 than it does about oxygen. We have very few oxygen sensors. So when you exercise, how many people have always thought your breathing increases because your oxygen demand goes up? Of course, that's what everybody thinks. But that's not accurate. That's not the entire story. Do we get more oxygen as we breathe faster? Sure we do. But more importantly to your body, you're getting rid of CO2 faster. Your body cares way more about that than it does about getting oxygen out to your tissues. You guys are going to have to know more about TV, IRV, ERV, VC. These are all these things up here. We'll define the formulas for them. What is hypoventilation versus what is hyperventilation? We're going to be looking at some saturation curves tomorrow in lecture. So you probably won't be able to answer this bullet until tomorrow. What we definitely will be doing are these last 2 bullet points. We're going to be drawing, labeling, and looking at a spirogram. Obtain information means we're going to be taking these different defined words, figuring out where they are on a spirogram, and then being able to start to look at how much oxygen or how much air that patient is getting. Okay, cool. Why do we need to do this? I hope it makes sense, right? Why do we need to do this? Why do we need to start looking at respiratory physiology and being able to actually determine how much air is going in and out of our patient? Do I need to say COVID? All right, COVID is a great prime example of a disease that impacts the respiratory system first and foremost. What's going to start happening to the mechanisms of breathing? What's going to start happening to each one of these following? What's going to happen to the amount of CO2 inside of the bloodstream as we no longer can breathe as well? You see what I'm saying? Doesn't have to be COVID that we're talking about, though. It can just be asthma. So does anybody in here have asthma? Anybody here ever been to like an allergy specialist, an asthma specialist, a respiratory doctor in essence? Almost always have one or two people, but we only have half the class here today. So maybe somebody that's not here has been to one of these guys. But they make you breathe through a tube. And they're able to determine a lot about what's going on with the respiratory system simply by inhaling and exhaling through a tube. And the reason why is because as you inhale and exhale through that tube, you're force breathing for the most part. It displaces air inside of that tube. So as you blow through that tube, it's going to push air forwards. And they got membranes in there, these little membranes that can now be recognized by electronics, and we can measure how much air is being displaced. And then when you breathe in, you inhale, you're displacing air, and we can measure how much air is displaced. Does that make sense? We can measure all of this. And depending on how much air is getting in and out of your lungs, this tells us a lot about whether you have a fibrotic lung disorder, whether you have an asthma disorder, whether you have any sort of breathing disorder whatsoever. This contraption is called a spirometer. It's called a spirometer, spirometer. And spirometers produce a graph called a spirogram. And that's what we're going to be drawing today, is a spirogram. So as we draw this spirogram, what I want you guys to be imagining is air moving in and out of your lungs, moving in and out of a patient's lungs. How do we do that? We draw our graph. Here's our y-axis. Here's our x-axis. This is all about time. So as you're breathing in and out, this is a much slower process than an action potential. So this time is going to be occurring typically in seconds, not in milliseconds like it was for action potentials. Also, when we're talking about breathing, what we're talking about is displacing air, which is a volume. We're displacing a volume of air. So over here on the y-axis, what we're dealing with is volume. And volumes are normally measured in milliliters. Now, we have relatively large milliliters and relatively small milliliters for how this all is going to play out. And so what I want you guys to do, I'm going to use a pencil here. If I take and draw this line up, that means more oxygen's going into my lungs. And then as I breathe out, I'm breathing that oxygen out of my lungs. So this is volume of air inside of my lungs. Does that make sense? Cool. Release that pencil mark. Now, I want everybody to be thinking about, this is one of the hardest things in the world to do. I want everybody to passively breathe right now. Everybody passively breathe. Don't think about it. No, don't think about breathing. Just don't think about it. What's wrong with y'all? Don't think about breathing. Don't think about it. How easy is it, especially when somebody's hounding you? How easy is it to passively breathe? when you are actively trying to passively breathe. It's almost impossible. And when you got a patient, they're going to be hooked up. Let me show you guys pictures of this. It's relevant. I think it's helpful. So when you're hooking a patient up, they basically have these huge tubes hanging out of their mouth and a nose plug on, trying to make sure none of the air escapes through their nose, or tube like, y'all, passively breathe. Now imagine your patients hooked up to this shit trying to passively breathe. This is one of the hardest tests to get done accurately. I swear, it's all dependent on your patient. How much are they willing to work? How much are they willing to try to passively breathe? Kind of crazy, huh? Like, they're literally supposed to have this stuff hanging out of their mouth. And in labs, by the way, in-person labs, cracks me up because every other lab partner is just busting a gut. As one lab partner has all this stuff hanging out of their mouth, and the other 3 lab partners are pointing fingers and laughing at them, it's not easy to passively breathe when all that is going down. I think it's important to sympathize with patients, and that's kind of why I make sure to point all this out. Like, if you're going to make a patient do this test, have some sympathy for them. You know what I mean? Because this is not going to be easy, and they're going to have to practice. It might take hours to get it done right. Does that make sense? I don't know if I'm just talking around in circles here, but I think it's important. There's all sorts of breathing issues out there in the world around us. But let's assume that we get some passive breathing. Let's make that assumption. I think that's a good assumption that over time, we're going to figure out passive breathing. Now, as we breathe, everybody breathe all the way in, and everybody breathe all the way out. Does it stand to reason that passive breathing is somewhere in the middle of all of that? Right? There's always some oxygen, there's always some air inside of our lungs. So do we start down here at 0, 0 on this graph? Are we going to ever have 0 volume of air inside of our lungs? No, we're going to always start somewhere. Does that make sense? We're always going to have some oxygen in our lungs. And it's all going to be dependent on the person. But you're going to notice here in the lab handout that there are some volumes that are put in here for you. Okay, 1200, 1200, 500, 3100, and 4800. So we're going to be talking about each one of these. We're going to be talking about it in a lot of detail. We're going to be defining each one of these. But when we think about this graph that we're about ready to write, we need to make sure that we think about the fact that as we start to passively breathe, as air goes into the lungs and air goes out of the lungs, we are not at 0, 0. We are somewhere up here. So for instance, in this graph right here, there's 1200 mils underneath it and an additional 1200 mils underneath it. Don't worry about these 2 values yet. We'll go through those. So in this particular graph, tidal volume starts at about 2400 milliliters. So we go back to our graph here. We're not going to write in our numbers yet, but I just want you guys to make sure that you're thinking we're starting here on the curve. We're not starting down at 0, 0. Okay, that's enough of that. Now, breathe in. Now we're passive breathing, so it shouldn't be a lot of air. Passive breathing is not a lot of air. We're just breathing in, and then that's active breathing that I just did, and then breathing out. We breathe in, and we breathe out. And we breathe in, and we breathe out. This is passive breathing. And if we measure from maximum volume that has entered our lungs to minimum volume that's left over at the end of passive breathing, if we measure the distance between these 2 points right here, This is called tidal volume. This is what I already defined earlier today. This is tidal volume. And tidal volume, if we were to try to define tidal volume, TV, this is all going to be in mils. This is the volume of air during passive breathing. Both inhalation and exhalation. And this value is approximately, kind of wish I would have left more room. I'll draw it up here. This value right here is approximately 500 milliliters. This is what I already described earlier today. It's about 500 mils. This is the basics for a spirogram created from spirometry. Does everybody have a basic understanding of tidal volume? This is going to be controlled by your nervous system. This is going to be controlled by your respiratory system, by the respiratory groups in your brain. And it's just going to determine how much air do I need right now, passive, not thinking about it. I need approximately this much air. Most given times, it's about 500 mils. Now, everybody breathe in as deep as you possibly can. What's happening to the volume inside of your lungs? Increase, decrease, no change. Good. So this right here, if I were to take a nice, huge, deep breath in, I'm going to go past the volume that was passive breathing. Everybody breathe in as deep as you can. And then breathe out as deep as you can. So again, take a couple of nice, shallow breaths here. I don't want you guys passing out on me. Now, everybody, you're going to breathe in and then breathe out without pausing. Breathe in as much as you can and then breathe out as fast and as hard as you can, all the way down until there is no more air that you can push out. Everybody, breathe in, breathe out. The volume of air from where you started to breathe in is at the peak of tidal volume, okay? This value starts at the peak of tidal volume, and it's going to go all the way up until you can no longer breathe in air. You can't. You physically can't. Your lungs will not expand anymore. This is all about inspiration. So this is called the inspiratory reserve volume. This is the volume of air that's in reserve. If you need to breathe more oxygen, we have this much lung space to do so. Does that make sense? We could really simplify this. By defining it as the max volume of air, basically, right? From tidal volume to max. From the top of TV to max volume. That is about 3,100 mils. Now, as we breathe out, we're breathing out all the excess of air, going from the bottom of tidal volume, and we're going to keep breathing out, breathing out, breathing out, until we literally can't breathe out anymore. Our lungs cannot collapse any more than this. We can't make our thoracic cavity volume any smaller than this. This is called the expiratory or expiratory reserve volume. This is our ERV, which is expiratory reserve volume. The RV is approximately 1,200 mils. Approximately. Just depends. That's the average. But if we want to define this, this is the maximum amount of air that we can blow out of our system. From the bottom of TV to minimum volume of air. Right? So from the bottom of TV to min. It's how much you guys have available. You're going to find that the expiratory reserve is much less than the inspiratory reserve. We can breathe in a lot more than we can breathe out. What you'd make your patient do then is they try, it's pretty hilarious trying to watch people do this, but you're going to try to get them to go back to passive breathing. Yeah, right. Breathe in as deep as you can, breathe out as deep as you can, and then return immediately to passive. It's not easy to do. What do you guys notice? Is there air always left inside of those lungs? There's always air left over. There's always some residual volume of air. So from the bottom of your ERV all the way down to 0, 0, we're never going to get rid of this volume. If you did, your alveoli would surely collapse. There would be no coming back from that. This is the residual volume. This is everything that's basically not being used, but it's there to help keep your lungs inflated. Residual volume. And the residual volume, RV, is also about 1,200 mils. Depends on the person, of course. This is the volume of air always left in the lungs. Awesome. These are the 4 big ones that you guys need to know, and then you're going to have to do some math to figure out the rest of them. Okay? But it won't be, I mean, it's not complicated math at all. I promise. Some of the other ones are just a combination of these others. So for instance, if you want to look at what's happening from the bottom of your tidal volume, and you want to say, how much air do we normally not use? We'd say everything underneath passive is normally not used. Does that make sense? This is called the FRC, which is the functional residual capacity. The functional by the way, in case you guys ever get lost on all this, don't forget that your labs have everything that I'm going through. So if you guys are getting lost on tidal volume, IRV, ERV, residual volume, it's all here. I just am not the type of professor that just says, and go figure it out yourself. It's just not my style. Now, if I want to start looking at how much air do I have available for life, then I start saying, well, if I can use it, it's available. So what air in my lungs is available? Well, residual volume, that's not available. No way, no how. Everything here is available, and it's all vital for my life. So this is vital capacity, otherwise known as VC. The last value is, man, even our lungs need a little bit of tender loving care. Everything needs a little TLC. Don't go chasing waterfalls. Functional residual capacity, Heather. We'll come back to it. This over here is TLC. Obviously doesn't really mean tender loving care. It means total lung capacity. Each person has a total volume of air that their lungs can hold, from the absolute max to 0. That's TLC, total lung capacity. So let's do, I'm out. We'll do it on my scratch paper. What I'm going to do for you is I'm going to teach you guys how to answer some of your lab report. And using this, you're going to be able to answer a ton of your lab report. How does this work? Well, there's this weird thing at the end of your lab report. It says on graph paper, draw a spirogram. You have to do this. I'm pointing out this to you guys right now because students don't read well, not just students. My wife always complains that I don't read all of her texts. But if she highlighted, anyways, we won't go there. Every group needs to make sure that they get their graph done. You don't need to use a graph paper. You can use Excel. I don't mind. But every single group needs to make sure that they submit a graph with their lab reports this time around. Is that clear? Let me say that again. Is my vocals better now? Am I less of a robot? No? All right. I don't know what to do because it shows that I have full bars on my side. I'll be back. That's the only way that I know how to do it.
Bueno. Sweet. Awesome. Just did it. You tried turning it off and turning it back on again. The answer is I just did. Okay, so lab. Every single lab group needs to make sure that they submit a graph with their lab reports this time around. Is that clear? Now, what will you need to draw? What will you need to graph? You could use Excel, you can draw by hand, just make sure it's all done right. What you're gonna wanna do is you're gonna be showing 2 tidal volumes, 1 vital capacity, just like we just did, okay? We just did 3, 1, 2, 3 tidal volumes, max min vital capacity. So we just drew exactly what you guys need to do for your lab report. You're welcome, right? That's what I'm trying to get you guys to do. Now, normally, you'd be using some data. one that you guys did in class. Well, you don't have any data from class. So what you're going to use is just, what did I just hit? What did I just hit? Go back. All you're going to use is this data down below. Okay, you're going to have to make sure that you label IRV, TV, ERV, RV, VC. The graph must be proportional. You don't actually need to write the numbers in for the x-axis or y-axis. I'm going to talk to you about it. One, because I know students had trouble on the last lab practical, and two, because sometimes I ask students to do it, even though the lab here specifically says that you don't have to. So listen to what's on here, not necessarily to me in this regards. Now, what you're going to get is you're going to get some values. You're going to be able, I'm giving you pulmonary ventilation, I'm giving you ERV, I'm giving you respiratory rate, I'm giving you total lung capacity, and I'm giving you FRC. But the problem is that's not every single variable that you guys need to draw into your graph. You need to draw in TV, FRC, IRV, ERV, VC, TLC, RV. You need to be able to put all of these values in, and I don't give them all to you. So how are we going to go about calculating each one of these? Well, that's where this cool box comes into play. Students used to freak out about this. I did not sit people down to study this crazy weird table, but it simplifies simple math. It simplifies simple math. We'll just go there. Let me explain this to you. Everybody take a second. Let's do more than a second. I want everybody to pull out a scratch piece of paper. And I want you to draw this exact table right here, this exact table. Can you guys do me that favor, please? Take a minute. Let me know. I'll do a poll. Tell me when you're done. I'll do a poll. It just says finished, so click yes when you are done. Move the poll. I think you have to move the poll up. I can't move your poll. Down below, there's a button. Where's it at? Down, it kind of looks like a graph down below. You just click on that and it'll view the poll, and then you can hide the poll, view the poll, hide the poll. Did that help? Lovely. Yeah, no kidding. Heather, Becca, Sabrina, Sydney. You down below, Heather, on your screen, there's something that looks like a graph. You got, the microphone, the video. Cool. And then Sydney. If you're around. Maybe Sydney stepped away for a minute. Okay, so this is an important part of this lab report, and it will be an important part of the lab practical, so that's why I'm making sure to go through it with y'all. If you mess this up on the lab report, you're going to miss multiple points on your for your grade, for your entire group. So that's why I want to emphasize this. Now, how does this table work? This table works exactly as follows. I'm going to show you guys this as an open table. Let me do it this way. I want to show you guys these two things side by side. I like the way that turned out last time I did it. Yeah, this is going to work just fine. All right, so I just drew in the columns because I want you guys to be thinking about what I'm about ready to write in. Now, if we also, at the same time as looking at this graph right here, or this table, I'm sorry, we want to be thinking about this graph, and we want to be thinking about each one of these variables. And if I was to look at the volume of air on the y-axis, volume, and I wanted to say, what is the total volume of air that the entire lungs can hold? Which one of these abbreviations accounts for the entire volume of air? TLC. And so when I look at this right here, this last column is TLC. And if you look at the lab report, you'll notice that there's no little subsets. There's no other boxes inside of TLC right here. It's just one gigantic open column because it's all of these values combined. So now let's take and look at what does TLC equal? So let's go back to our graph. And if I were to take TLC and I wanted to talk about all the different variables that make TLC happen, do you guys see that this is IRV, then I add TV, then if I added ERV, and then I added RV, that all four of those combined equals TLC. Yes, no, maybe so? So then I come back here, and that's what the second column says, is that there are four things, 1, 2, 3, 4. I got IRV, I got TV, I got ERV, and I have RV. IRV plus TV plus ERV plus RV all equals TLC. Pretty cool, huh? It's a mathematical way of looking at this. We can describe it. What about vital capacity? What's the only part of this graph that's not involved in vital capacity? It's the only part of this. So RV, oh, okay. So if I come over here and I take RV out of this equation, what am I left with? I'm left with VC. So what's another way to look at VC? Vital capacity is IRV plus TV plus ERV, or VC is TLC minus RV. Do you see how it could be either one of those? So this is a way to start looking at equations. We just have a summation or a subtraction of things. The last one that you guys learned about is the FRC. And FRC was just everything underneath tidal volume. So FRC, we don't have anything to account for the top portion of this graph. FRC, well, what is FRC? It's ERV plus RV. Is there another way to look at this? I mean, there's lots of different ways to look at this. Could just be TLC minus IRV and TV, and then we're left with FRC. Or it could be vital capacity, but we'd still have to subtract out IRV, TV, add back in RV. That would be a pain in the butt. So mathematically, we can actually determine all of these different things. TLC, for instance, IRV plus TV and ERV. Okay? You guys see how you can use this table to figure out the equations for everything. Now, there's one more equation. It's almost one. I want to be done now-ish for you. There's one more equation that I haven't taught you guys yet. It's actually a part of lecture. I was going to talk about it tomorrow, but then I was dumb because I got to talk about it today. What is this equation? This equation is called pulmonary ventilation. Pulmonary ventilation. I don't know why I didn't talk about this already. Pulmonary ventilation. Pulmonary ventilation is actually a great equation for you guys to learn. Ventilation, we know that this is the physical act of breathing. This is all about airflow, right? But just like in the heart, we're not concerned with just the amount of air that moves in a single breath. We're concerned with the amount of air going in and out of the lungs over time. So even on these spirograms using a spirometer, we're actually looking at ventilation over time, the total amount of air over time. Wait a minute. Okay, so what you're telling me, Dr. H, is that pulmonary ventilation is going to end up being the amount of air moving in and out of the lungs over time. Huh. This sure looks a lot like cardiac output to me, where cardiac output was the amount of blood ejected from the heart, the volume of blood ejected from the heart over time. True story? Why did I write seconds? I don't know why I wrote seconds. I'm sorry. It's per minute. I'm so sorry. It's the amount or volume of air over a minute. Well, that's the exact same thing as cardiac output. So pulmonary ventilation is the respiratory version of cardiac output. What do we know about cardiac output? Cardiac output equals heart rate times stroke volume, where heart rate is the beats per minute. Well, we're not going to have beats per minute in the respiratory system, are we? Are we? Pulmonary ventilation, what are we going to have that determines how many times you breathe over a minute period of time? This is the respiratory rate. Does that make sense? We want to measure every single patient that comes through the door. You're going to measure their respiratory rate. It's part of one of the major roles of a patient walking through that door. You've got to do blood pressure, heart rate, and respiratory rate. It's a pretty big deal. The respiratory rate is RR. It's also sometimes known as the ventilation rate, which is VR. I like RR better. And the respiratory rate is breaths per minute. Let's just get rid of that. Let's just talk about respiratory rate there. So cardiac output, heart rate times stroke volume, where stroke volume is the volume of air, volume of blood that goes out of that heart during each cardiac cycle. The volume of blood going out of the heart in a single beat. Well, we don't have beats in the lungs. We have breath in the lungs. And those breaths are going to determine the volume of air that go in and out during a single breath. Are you guys with me so far? We're talking about passive breathing because most of your life is done just passively breathing. And which one of these values here is breathing? Normal, everyday breathing, the volume of air going in and out of the lungs during normal breathing. That's tidal volume. So tidal volume now tells us, what is that? That's not a T. Tidal volume now tells us how many mils are moving in and out of the lungs over time. Not over time, per breath. What is wrong with me? Trying to speed up because it's after 1, but all I'm doing is making mistakes. It's like the end of an exam where you're just like writing anything you possibly can. Pulmonary ventilation is mils per minute. The respiratory rate is breaths per minute. The tidal volume is mils per breath. Well, let's take these and let's say breaths per minute, and let's do exactly what we did up here, multiply it by mils per breath, and what are we going to be left with? Breath schnicky, cross cancel. Now we're left with mils per minute. Isn't that what we wanted? So pulmonary ventilation is equal to respiratory rate times tidal volume. Oh my God, it's the exact same equation. One's just dealing with heart function and the other one's dealing with lung function. Helpful? Helpful that we've hammered this home so hard. So what 2 variables control your pulmonary ventilation, everybody? What 2 variables control pulmonary ventilation? Help me help you. So what 2 variables is your brain going to change, right? What 2 variables is your brain going to change to increase or decrease pulmonary ventilation, depending on the body's demands? Just be redundant. I love it. Just be redundant. We'll be talking more about that tomorrow because this is how the medulla oblongata is going to say, breathe more, breathe less. We need to make sure that we have proper pulmonary ventilation. That's homeostasis, just like cardiac output is homeostasis. This is pulmonary ventilation. Now, are we done? God, I wish. We're not done because why? Because just because we get air into our lungs doesn't mean it's usable. Everybody take a deep breath in, deep breath out. Carbon dioxide's left in your tubes, breathe in. We breathe that CO2 right back in again. Because summer. That's our answer for everything now, summer physiology. But it's because of dead space. Do you guys see that not all the air you breathe is available air because some of that air is dead? It's CO2, it's not O2. To us, that's dead. It's not usable, so we call it dead. What we care about is usable air. And usable air is found inside of our alveoli. So instead of calling it pulmonary ventilation, we can call it alveolar ventilation. AV stands for what amount of usable air goes into our alveoli over time. We already got the equation set up for this. Okay, we already know that alveolar ventilation, it's going to be very similar to pulmonary ventilation because it's just the amount of air going in and out over time. So we still want mils per minute. So we're still going to be dealing with the respiratory rate. Cool. And we're still going to be dealing with the tidal volume. Awesome. Tidal volume is normally about 500 mils. Remember that? That's the amount of air going in and out of the lungs during each breath. It's about 500 mils. Now, what is the difference between alveolar ventilation and pulmonary ventilation is we need to take into account the amount of dead air. That dead air, CO2 rich air, is called dead space. Dead space is abbreviated as DS, and it's approximately 150 mils. So if every single breath you take, you're breathing about 500 mils, but of that, about 150 mils is dead, how much usable air do you have? It's about 125 to 150, just depends on the person. Does that make sense that this is going to be about 350 mils of usable air? So that's what we need to take into account over here is we are going to take and look at alveolar ventilation. We're still using respiratory rate. We're still using tidal volume, but we need to take into account that some of that volume is dead. Boom, done. Alveolar ventilation is just respiratory rate times TV minus DS. And please don't forget, if it's in parentheses, we have to do that math first and then the rest of the math. Whatever's in parentheses gets done first. True story? Awesome. Cool. Now, let's go back to our lab report. Yeah, physiology just builds. It just builds and builds and builds. Let's go back to our lab report and let's look at some of these first questions. VC equals what plus what plus what? You guys feel more comfortable being able to do that now that we have this? VC equals what plus what plus what? Boom. Using the answer from A, if I had to recalculate this and solve for TV, if I had to recalculate and solve just for TV, how can we do that? Well, we already know VC is equal to IRV plus TV plus ERV, but now we got to solve for TV. Well, that's going to be VC, but we have to subtract out what two values? Not TV, Veronica, because we're solving for TV. You're on the right track, though. We're actually solving for TV in this question. So TV wouldn't be part. That makes sense, I'm sure. You probably just... Perfect. So same thing. You just use this table. Answer. What is FRC equal? What is TLC equal? But we only want two values. So if I'm going to take TLC, but I'm only given two values, there's only two things that can add up to TLC. What is PV equal? Y'all write it down. Redundancy. Just like we did cardiac output over and over and over. So now take that and solve for TV. If we take PV and we solve for TV, remember what you got to do is get TV isolated. TV, to isolate it, what do we need to divide both sides by? You may or may not remember this. Do you guys remember how to do this basic pre-algebra stuff? I never remember what people remember. If I have PV equals RR times TV, how do I get rid of RR? What do I need to divide the right side by to get rid of RR, y'all? But I can't just magically get rid of RR on one side of the equation. I also have the exact same time, I have to divide the other side of the equation by the same thing. I gotta keep things constant. Math is not magic, as much as sometimes it seems like magic. On the right side of the equation, those RRs will cross cancel. On the left side, they don't. So now what do we know about TV is that TV is equal to PV divided by RR. Does that make sense? Okay. I know people have trouble with the math, so that's why I cover it. I get students that literally break down in tears. It breaks my heart because they get so anxious over math. They're so damn smart, and they get so anxious over math that it shuts them down. Can't do that in a nursing program. They'll just kick you out, no matter how smart and how compassionate you are. They don't care. They can't have you killing patients, so you got to work through some of those anxieties. We'll talk more about questions 3 through 8 tomorrow in class. We'll talk about hyperventilation and hypoventilation. We'll talk more about saturation rates, oxygen saturation rates. So now let's go back down to this table. This is it, guys. I promise. This is it. And then I'm gone. I'm done. What do I give you? That's what you guys need to be thinking about. These are givens. Okay, I give you pulmonary ventilation. And I tell you pulmonary ventilation is 6,800 mils per minute. Awesome. I give you ERV. And I tell you that ERV is 1,050 mils. I give you the respiratory rate. And I say that the respiratory rate is 16 breaths per minute. I give you the TLC, and I tell you that the TLC is 4,300 mils, and I give you the FRC, and I tell you that's 1950 mils. And now the problem is you need to fill out this entire table with values. Do you guys see what you'll need to do for your lab report? So why is this a problem? Because I only give you a few values. Which ones can we fill out already in our table? Hint, hint, I put them over here on the right. So in our table, we already know the ERV. So I'm going to add that in. I know this is 1,050 mils. I already have the TLC. I know this is 4,300 mils. And I already have the FRC. I know this is 1950 mils. Is there something I could do with this already? What can I already calculate based on this information? Good, quick response there, Andy. Can everybody else see that FRC, well, that's equal to ERV plus RV. So if I have two of those variables, I can calculate the third variable. How do I do that? I simply solve for RV. And if FRC is equal to ERV plus RV, well, if I'm going to solve for RV, then I have to subtract ERV from both sides. So that's going to be equal to FRC minus ERV. And boom, I can calculate RV. Make sense? So what's RV going to be based on this information? 900 mils. I'm kerbongled though now. I'm kerbongled. Why am I kerbongled? I don't even know what that word means. I just made it up. Discombobulated, discombustulated. I'm combusting. I can't do anything else yet. But what other two values? Can't do VC yet. How are you going to get VC? Good try. I guess technically you can do VC. Sure, you can do VC. Sure. Yeah, we got great. Wonderful. Andy, Veronica, you guys are on it, right? Because we have TLC and we have RV, now we can calculate for VC. Awesome. What's VC going to be? 34. Yeah, I'm bad math. I need to have, oh yeah, definitely 34. 36, where does that come from? Doesn't matter. That's what calculators are for. JK. So the last one is the hardest one, and I'm going to let you guys figure out how to get the last one. But don't forget, you have 2 other givens. What do these givens have to do with these 2 variables that are left over? I'm going to let you guys figure it out. Fair enough? I've gotten you to that point. All right, awesome. Guys, tomorrow, be here at 9. We have to get through the rest of this respiratory system stuff. We have to get through the rest of the respiratory stuff and at least start talking about digestive. So be here on time, be here early, pretty please. Send those texts to your lab partners. Make sure everybody's on time tomorrow because I'm going to get started probably even a minute early. All right, you guys rock. Text me if you have any questions. Have a great Wednesday. Adios. Dang it. I'll tell you tomorrow in class. If anybody's still here, which I doubt, anybody's still here? Don't forget, Monday is a holiday. It's the 5th. It's the day after the 4th. But Monday's a holiday. For the 3 people left. I'll make sure to remind everybody. Can somebody help remind me to remind everybody tomorrow? I probably won't forget, but just in case. Monday's a holiday, so nothing's due on Monday. This lab report will be due next Wednesday. All right, awesome. Thank you. Bye-bye.